in Ophthalmology meeting this year. The conference is organized by Foundation Ophthalmology 21 with the University of Varga and Mazuri and two companies, Alpha Event and Mark 21. We also have distinguished sponsors, as you see, Oko Foundation, Viatris, Magna Farm, and Lumibeard. We are happy to have media patrons, including Journal of Clinical Medicine and Medicina Practitioner and the Ophthalmologist magazine. Our foundation has organized this year a few other meetings, just to mention them. AI in Ophthalmology, this is the meeting that was held, as you see, in June. This is related to the AI in Ophthalmology Society. Everybody who is interested in this topic is welcome to join our group. We have already 1,400 members in this society, and the registration, the membership is free. Then we also organized the myopia meeting, again June this year, and this is the it shows our deep interest in this topic. Then a new conference that was held this year for the first time, Science and Tech Innovations in Ophthalmology, in September, and quite recently this month, Presbyopia meeting that of course was related to the presbyopia topic. During today's conference, we have several sessions. The session number 1 will be moderated by Professor Maciej Gawęcki from Poland and Professor Lubomir Litwinczuk from Germany. And this session will cover interesting case reports from Philippines, Nepal, Poland, and Puerto Rico. Then it will be, of course, discussion, and everybody is welcome to put questions at the chat for the moderators and the panelists to discuss the cases. Then the session number 2 will be moderated by Professor Stephen Schwartz from Bascom Palmer at Florida, US, and Dr. Perfecto Kagampañ from Philippines. Here we see the program of the session 2 with the cases from Poland, Ukraine, and UK. Session number 3 will be chaired by Professor Ewa Kosior-Jarecka and Professor Anna Machalińska, both from Poland, and Professor Gustavo de Morales from US. And as you will see, during this session we will present cases from Philippines, US, and Ukraine. Finally, session number 4 will be chaired by Dr. Agnieszka Kardaszewska and again Dr. Perfecto Kagampañ from Philippines. And this session, during this session, the cases from US, Lithuania, and Poland and US again will be presented. During case reports in ophthalmology meeting, we also are happy to invite a special lecturer to provide the Ksawery Gałęzowski lecture. This is the opening lecture, and we are proud to have very prominent clinical researchers in the recent years, starting with the Professor Francesco Bandello in 2021, then Professor Ningli Wong from China 2022, and last year this lecture was delivered by Professor Stephen Schwartz from US. Who was Gałęzowski? Gałęzowski, as you see, according to one of the prominent German ophthalmologists at that time, because he lived, as you see, in the second half of the 19th century, was assumed one of the best practitioners and surgeons in ophthalmology in those days. He was a pioneer of ophthalmoscopy in the diagnosis of central nervous system disorders. He coined a term cerebroscopy. He published a book on this topic, as you see, in 1866, how to use ophthalmoscopy for diagnosing the disorders of the central nervous system. He also introduced the ignipuncture, cauterization of retinal ruptures after evacuation of subretinal fluid for retinal detachment treatment. So very early, he was one of the pioneers of retinal detachment treatment. So as you see, he was born in 1832. He graduated from medical faculty in St. Petersburg, and he wrote a doctoral dissertation on ophthalmoscopy. Then he moved to France, where he lived till the end of his life. He was trained under famous French ophthalmologist Demar, and then he founded his own private hospital, and he became one of the best practitioners, and his hospital was one of the best ophthalmic hospitals in Paris at that time. He was the author of about 300 articles, 12 books, so was very productive on nearly every aspect of ophthalmology. He was also a tutor to many French ophthalmologists, including, for example, Perrinot. We remember him with the eponym Perrinot syndrome. He founded the first French monthly ophthalmic journal, Journal d'Ophthalmologie, in 1872. And he also collaborated closely with Jean-Martin Charcot, a famous neurologist. He was his ophthalmic consultant, and where he gained a great deal of experience with neurological diseases, became the pioneer of the use of ophthalmoscopy in the diagnosis of central nervous system disorders that I already mentioned. He also designed several types of ophthalmoscopes. Here we can see a very original pocket ophthalmoscope by Gawęzowski, and here some other types. It's a tubular ophthalmoscope, again of his own design. Today I have an honor and pleasure to introduce Professor Ferenc Kuhn as the lecturer of Xaver Gawęzowski lecture. And the title of his presentation will be Case Reports in the Life of Vitreoretinal Surgeon. Professor Ferenc Kuhn graduated from the University of Pécs, where he became also certified in ophthalmology. Then he was trained in several institutions in Europe and US. Then he became an associate professor and deputy chairman of the Department of Ophthalmology at the University of Pécs. And in 1989, he moved to Birmingham, US, where he was appointed associate clinical professor of ophthalmology at the University of Alabama, and then he became also a professor of ophthalmology at the University of Pécs. He was elected to be executive vice president of the International Society of Ocular Trauma in 2000, and later became its president. Also was a president of the American Society of Ocular Trauma. He received his PhD degree in 1999. He played a key role in the development of the United States Eye Injury Registry that served as a model for similar surveillance systems in 25 countries. He authored over 200 scientific articles and book chapters, edited 4 books, presented more than 1,500 scientific talks, visited over 50 countries as invited speaker, and gave named lectures in several countries. He was the principal author of a new standardized language in ocular trauma so-called Birmingham eye trauma terminology, the proposal has received the endorsement of several international societies and journals and has become the international standard in classifying eye injuries. He serves as editor at 11 national and international journals, traveled extensively, and performed live surgeries in 17 countries. So we are very proud to have Professor Ferenc Kuhn with us today. Please listen to his lecture.
Hello. This talk is about strategic decision-making in ocular traumatology. I have no financial interest in the talk. The eye surgeon's dilemmas in traumatology include the following if we are talking about strategy. The first one is whether to do surgery or not. And a good example to show when you would not do surgery is a hemorrhage as a result of contusion. The next question is if you do surgery, whether you do it yourself or you would better refer the patient to another surgeon. The next question is about timing. You can do a now surgery, which means you do a primary comprehensive intraocular reconstruction, everything from the cornea all the way to the subretinal space. Or you can delay the surgery. One option of delay would be just a little bit of delaying it, which means you do surgery in the first 4 days, or you delay it a lot, which means weeks or months. The final statutory question is the type of surgery you would do. Of course, you would close the wound, clean the anterior chamber from blood, etc. But the big question is whether do you posterior segment work, vitrectomy, yes or no. But so far we have been talking about acute cases, which means the patient comes to you shortly after the injury. But what do you do when you have a chronic injury? And one good example of this is the following case. It's a chronic intraocular foreign body which was accidentally discovered. The patient has no symptoms, visual acuity is full. In fact, the patient doesn't even know there is a foreign body in the eye. It is a ferrous one, it is encapsulated, and it's sitting on the posterior pole. And here is the image showing the now subretinal intraocular foreign body. The other option, of course, is to remove the foreign body, but as I mentioned, you have surgical risks. Anything from retinal detachment to endophthalmitis, PVR, etc. The best in such a case is to discuss the case in detail with the patient and make the decision together with the patient. You have to tell what to expect in case there is no surgery and what if there is surgery. So in this case, this young man decided to undergo surgery rather than to do regular checkups. So again, you see the encapsulated foreign body, which is close to the macula at the vascular arcade. The first step of surgery, of course, is do a vitrectomy, which must include the detachment of the posterior hyaloid. Even in this case, we are 1 year after the injury. As you can see, there is no PVD. This is very important to realize and not defer surgery at a later stage just because the surgeon expects a spontaneous posterior vitreous detachment as described in the literature in a few days. You cannot accept that as a fact. Most of the time, even if there is some vitreous separation, it's a vitreouschisis, not a detachment. You can also see that you require not just aspiration, but a sharp tool to detach this very adherent posterior hyaloid. And I want to emphasize it again, you must never leave it on the posterior retinal surface. Step number 2 is to peel the ILM, and I'm using, of course, green dye, ICG, to make it visible. The reason to remove it is because it may be seeded with cells which can get activated after the surgery, and you can have a macular pucker, and then you have to go back and redo the surgery. The third step is a crucial one again. You have to remove the capsule from both over and under the foreign body. If you don't do that, and you can probably extract this foreign body without opening the capsule first, but it has tremendous risks of causing a larger retinal rupture or a choroidal bleeding, because you have no idea how the eye looks underneath the foreign body. You don't know what connections it still has to the choroid. So as you can see, I'm using various sharp tools, from blade to a needle with a hook on it, to an intraocular scissors, to make sure that before extraction of the foreign body is attempted, there is no connection between the capsule and the foreign body is left behind. A little bit of bleeding, because as I said, you don't know what is behind, underneath the foreign body. But once it's freed, and in real life it took longer than what you saw in the video, you have to open the sclera, and I always make a fourth incision, not enlarge an existing one, because then it's very difficult to tighten it back to its original size. And the size of the foreign body cross-section will determine the length of the incision, but in this case it's a relatively small foreign body, so really it is the size of the magnet that will determine the size. And you must, as we saw on the video, open the choroid underneath the sclera with venous scissors to make sure that the foreign body doesn't get stuck underneath. And then you carefully, very slowly, remove the foreign body, because what you don't want is, one, it to drop back on the retinal surface, and two, to get stuck under the wound, because then it's very difficult to find it. After that, you resuture this wound and complete the surgery, which in this case will include chorioretinectomy. The reason to do that, and you do this with the diathermy probe at its highest setting, is to make sure that no PVR comes from this area. You have to kill the pigment epithelial cells in the affected area. With this, and there's no laser over this, with this final step, air fluid exchange surgery is complete with a gas injection. And this patient maintained excellent vision years after the operation, and you can see that the retina amazingly closed over the impact site. So this case worked as planned, but the question is, what do you do next time when you see a patient with a chronic intraocular foreign body? And there is no absolute answer. You have to make that decision in every case, again, discussing it with the patient. Thank you very much.
Good day, everyone. I am Esther Carmen Arbella Ereño from the Southern Philippines Medical Center, here to present a case entitled Pimple Popper. This is a case of a 25-year-old male Filipino from Davao City, Philippines, who came in for bilateral eye swelling. Above symptoms started 5 days prior to consult when patient manipulated a pimple on his nasal area, initially with his fingernails, then used an unsterile needle. Few hours after, patient noted swelling of both eyes associated with eye pain, which gradually resolved. No consult nor medications were used. In the interim, noted worsening of eyelid swelling, now having difficulty in opening both eyes, associated with worsening headache, with no eye pain nor blurring of vision noted, prompting consult at our institution. Past medical ocular family and personal history were unremarkable. On review of systems, patient was noted to have dental caries and history of colds. On examination, bilateral middle malar and nasal area were erythematous, swollen, and tender. There were bilateral erythematous lids with swelling, with no proptosis, and no bruit was observed. Pupils were briskly reactive to light with no RAPD. BCVA was 2025 on the right and 2020 on the left. Intraocular pressures on the right eye was elevated at 28 millimeters mercury. Anterior segment exam revealed diffuse injected conjunctiva with trichomosis on both eyes. Gonioscopy showed open angles with no blood in the Schlemm's canal. Fundoscopy was also unremarkable. Extraocular movements were limited, and the rest of the cranial nerves were intact. Highlighted in the red arrow is where the patient pricked his nose. This patient was then admitted, and baseline infectious workup was done, as well as radiologic imaging was also requested. Laboratory results showed leukocytosis with neutrophilic predominance. HbA1c HbA1c was elevated and platelet function was deranged. CT angiogram showed dilatation, wall enhancement, and non-contrast opacification of the bilateral superior ophthalmic veins, with note of bilateral periorbital soft tissue swelling and fat stranding extending to the nasal region. There is forward displacement of both orbital globes noted. Patient was started on broad-spectrum IV antibiotics, topical antibiotics, and topical anti-glaucoma medications. Patient was co-managed with internal medicine for glucose control, ENT for the sinusitis, and dental service for the dental caries. Significant improvement was noted since starting IV antibiotics. Intraocular pressures were normal, and EOM limitation and chemosis gradually resolved. Patient was then discharged afterwards with follow-up after 1 week. Which vein is responsible for most of the venous drainage of the orbit? Right, it is the superior ophthalmic vein. Superior ophthalmic vein originates in the superomedial orbit, coursing along the superior orbital artery, passing through the superior orbital fissure, and ending in the cavernous sinus. It is the main draining venous structure in the orbit. Due to its anatomic relationship, thrombosis in the superior ophthalmic vein, shown with a red circle, may progress to cavernous sinus thrombosis. Superior ophthalmic vein thrombosis is an extremely rare condition with an incidence of 3 to 4 cases per million per year. From 1975 to 2019, only 69 cases of SOVT were recorded. Of which data from 2006 to 2014 yielded only 9 radiologically confirmed cases of SOVT. In the Philippines, there are no published literature available. If left untreated, this can lead to life-threatening conditions and vision loss. In patients presenting with orbital symptoms, it must be considered as it carries a higher morbidity. Inflammatory cascade culminates thrombosis caused by direct vascular invasion by the pathogen, the most common pathogen being Staphylococcus aureus and anaerobic streptococci. Superior ophthalmic vein congestion occurs as a result of aseptic or septic etiologies. Aseptic etiologies are due to facial trauma, cavernous sinus fistula, and hypercoagulable states. Septic causes include sinusitis, orbital infections such as orbital cellulitis, dacryocystitis, dental infections, and facial cellulitis. The most prevalent underlying etiology for SOVT is orbital cellulitis. Clinically, patients present with orbital swelling, painful ptosis, pain, and decreased vision. Optic nerve may be affected with optic neuropathy, color vision changes, and relative afferent pupillary defect. Neuroimaging, particularly contrast enhanced CT or MRI, aids in detecting this disease entity, which shows dilatation of the superior ophthalmic vein with internal filling defects and fat stranding around the vein. Rapid treatment is imperative in treating this condition. Treatment depends on the underlying etiology. In septic SOVT, mainstay treatment is medical using broad spectrum antibiotics. In aseptic SOVT, high dose steroids may be used with tapering on the succeeding weeks. Systemic anticoagulants are given to prevent progression to CST with IV heparin as a recommended treatment. Surgical drainage may be done to orbital abscesses as well. The final diagnosis for this case is bilateral superior ophthalmic vein thrombosis. In order to prevent devastating consequences of SOVT, a good clinical eye is needed in diagnosing this disease entity. A multidisciplinary approach aids in clinching this diagnosis and in treating patients with SOVT. With its occasional occurrence, a high index of suspicion should be employed. This ends my case. Thank you for listening.
Hello everyone, I'm Dr. Pratap Karki, lecturer and VR specialist based in Tribhuvan University, Nepal. And in today's case reports, I want to present a unique eye disease in Nepal. So it dates back to 1975, beautiful city, Pokhara, in Nepal. A child arrives with a history of sudden unilateral redness and marked diminution of vision in his eyes, in his one eye, since the last few days. And there's a little or no pain. This happens in the post-monsoon season. There's no history of fever, trauma, or similar illness in the past. On examination, the clinicians find that the child has severe loss of vision in his affected eye, and the clinical condition looks something like this: hyperpine with dense exudates, and the exudates blocking the pupil, leading to a leukoporia. However, child loses his vision despite the best effort of the doctors. But something peculiar happens. Around the same time, 10 similar cases, all from the same area, also arrived to the hospital for a similar history, and at the end land up with poor outcomes. Nothing happens next year, but again in 1977, the same thing happens. Similar cluster of cases in and around Pokhara area, post-monsoon season, affecting children. There's red eye with the white people. The children don't have much pain. It's a unilateral involvement, and again, in most cases, there's poor visual outcome and poor anatomical outcomes. And this trend doesn't stop here. It happens again in 1979, 1981, 1983, 1985, and this all goes on. In every alternate odd years, we have the same pattern, post-monsoon season, somewhere starting around August till November, December, same clinical patterns, same season, similar pace around the same geography located in Nepal around Pokhara, and there's a cluster of cases involving more children and young adults, and those patients, most of them have poor outcomes. And the mystery really remains: what is happening here? But there's something I didn't tell you about the history. There's a rare association with moths. Around the same time this epidemic occurs, there's a cluster of the increased number of moths in the environment, and the population of the moths also increase in alternate odd years. And in significant number of cases, there's history of direct contact with the moth preceding this incident. This moth later on was identified as Gazelina chrysophora, which you can see in the picture. And not more. And we have even noticed that moth hair. Some patients, before they go into full-blown cases, do arrive with moth hairs seen in the corneas. As you can see in this picture, moth hairs in the cornea, and this is an anterior segment OCT demonstrating it. But what is the diagnosis? Back then, the doctors, ophthalmologists, had two diagnoses. First was a seasonal endophthalmitis, because you can see the full-blown case look exactly like endophthalmitis, minus leukodystrophy and severe pain. But the second term, which we now use, is seasonal hyperacute panuveitis. This was named by a professor from my university, Professor Madan Upadhyay, and also we know in short as SHAPU, and this is the terminology we use now. And the association of moth, WHO helped us in a case control study, and we found that a direct contact with moth would mean the chances of having nearly 7 times chances of having this disease. So we also made a classification based on the clinical findings, which was published in 2021. And the clinical classification based on mild, moderate, and severe. And a mild SHAPU just looks like a red eye. And sometimes in the early phases, the patient may be confused as conjunctivitis. There's some inflammation in the conjunctiva. The vitreous and posterior segments are quite clear. In moderate SHAPU, we have more severe anterior inflammation. There is hypopyon, exudates, and some inflammation in the anterior vitreous, but the posterior vitreous remains quite stable. And a severe case, what I showed you in the picture, you can see hypopyon, dense exudate in the pupil leading to leukoporia, and the B-scan scores dense vitreous opacities, including markedly thickened choroid and retina. So we treat this patient with stage-wise treatment based on how they come. Mild SHAPU, as we saw, inflammation in the conjunctival area, we just give topical steroids and antibiotics. Moderate SHAPU, which is more severe inflammation, we start intravitreal antibiotics, same like using ceftazidime and dexamethasone. And severe SHAPU, we do a core vitrectomy followed by antibiotics. So the management has similarity what we manage with endophthalmitis. But the question remains, what is the pathogenesis? Is it a purely immunological disease? Is it an infected disease? And what is the role of moth? Are these sheetaes or these moth hairs have toxins in them, which causes the severe inflammation once they enter inside the eye? Or is the moth as a vector transmitting microbes through the moth hairs when it comes in contact with ocular surface? Or is it something totally different, a cross-antigenic reaction leading to acting as a UV antigenic antigens? So the intraocular samples were examined by different doctors from different hospitals over these years, and a wide array of organisms isolated: Staphylococcus pneumoniae, Actinobacteria, Staphylococcus, Streptococcus pyogenes, and even some viruses like varicella zoster virus, herpes virus 7, annulovirus. So we had a lot of findings, but nothing was so conclusive to explain exactly what was happening. So we are going in beyond now. We are doing moth studies like moth taxonomy, DNA analysis of the moth, ecology, rearing moths in laboratory to understand the story from the other side, how and why this disease is happening. But I'm here not to tell you the answer of this mystery, because the mystery still remains unsolved. We have come a long ways, nearly 50 years now, and we know a lot about this disease, but still still have more questions than answers. And still today we are this is an unsolved mystery for us. Thank you.
Hello everybody. Today I would like to share with you quite a rare case of dry, I think, form of AMD, the case that we published with Professor Grzybowski already. The case refers to a female patient aged 85 that remained under the care of my ophthalmological clinic for several years. At presentation 5 years ago, she was diagnosed with intermediate stage of dry form of AMD. At the fundus of her eye, we saw confluent, predominantly soft drusen, without significant pigmentary abnormalities. Of course, he had additional tests performed. Her fundus was documented with color photographs. We also performed SOCT that confirmed presence of drusen, however, without any vascular changes in neurosensory retina. So the patient was advised to supplement according to RH2 formula and to regular checkup twice a year. This is how her fundus looked. We see that the confluent drusen and rather predominantly soft drusen on both color fundus photographs and also at the OCT scans. We see also at the fundus autofluorescence photographs that there are some deficits in the RPE, however located outside the foveal center. 2 years later, her vision in the right eye dropped to 0.25, which was significant, and she felt that. And we performed additional tests, especially SOCT, but also fluorescein angiography, because we wanted to exclude the presence of macular neovascularization. OCTA and ICGA also helped to determine lack of MNV. And why we did that? Have a look at these photographs. We usually start from the OCT. And as we see the elevation of the RPE with sub-RPE fluid over the choroid. On the right-hand side, you see the fluorescein angiography that rather reveals staining, referring to drusen, than leakage. And when we look at the indocyanine green scans at the top, we see that the right eye demonstrates rather blockage of the fluorescence, which is due to the presence of this RPE elevation and sub-RPE fluid. And there is also no sign of MNV at the level of choriocapillaris. 3 months later, the situation developed because besides the elevation of the RPE, we also saw the separation of the neurosensory retina from the RPE. So we had like stand-alone RPE and two spaces. We see that in subretinal space, the photoreceptors are elongated, quite similarly to the situation in central serous choroidopathy. So we confirmed the vascular tests, so we performed angiographies, again without any sign of macular neovascularization. What to do in such a case? It was a dilemma, because besides the results of all the available tests, we still had quite a strong suspicions of the presence of occult MNV. So we decided to try anti-VEGF therapy, and the patient received 3 monthly injections of aflibercept. However, without any significant functional or morphological effect. She remained stable with or without treatment. BCVA in the right eye remained at the same level through the next few years, so it was 0.25, and we are at the moment still monitoring these patients. We are looking closely at the results of the tests. So she has regularly performed SOCT scans, also color fundus photographs and fundus autofluorescence and angio-OCT. Her best corrected visual acuity remains stable at the level of 0.25. Here are the scans of the follow-up of the OCT. As we see, there is not very much change during this last 2 or 3 years. There are still standalone RPE with the subretinal fluid and also fluid located under the RPE. When you look at her fundus, it demonstrates the presence of drusens, and we also see that in the right eye the RPE experienced some more loss, because we see much more deficit in the RPE in this exam. So despite the fact that her vision remains stable, there is some loss of the RPE cells that we can note at this simple test. So, questions to be asked are the following. Is it wet or dry form of AMD? I believe it's dry, however, with lots of fluid. Then the main question is how to treat these patients, or rather how to manage these patients, to observe or inject, or let's say try more injections with anti-VEGF medications. And if observed, then what is the prognosis? Now, well, our choice is to observe, because we didn't confirm MND, the vision remained stable, and the morphological changes did not progress during quite a long period of time. However, in conclusion, we can say that this is a sort of a form of a new type of AMD, probably non-neovascular one, however, with very specific characteristics with both subretinal fluid and subarachnoid fluid. Generally, observation proves its stationary character. However, I believe that we have to look at this case and probably more such cases closer to provide more relevant conclusions and more relevant recommendations for treatment. Thank you very much for your attention.
Dear colleagues, it is my pleasure to talk about AI-supported diagnosis today. This talk was prepared by invitation by the company Viatris. However, this company has no influence on the content of this presentation. Here are my financial disclosures. None of them is relevant to the topic of this presentation. So, as it was recently shown, fundus retina photography, can be treated as a very special source for the information that can be further used by artificial intelligence models for demographic medical data to diagnose ophthalmic disorders and to diagnose non-ophthalmic disorders. This study that was published already 6 years ago for the first time shown that AI model that was trained based on the fundus photos was able to evaluate the age, sex, smoking status, glycosylated hemoglobin level, body mass index, systolic and diastolic pressure, and in the meantime this study was confirmed by several other studies, so we are pretty sure that presently AI models can do that. We know also that the eye image or eye picture can be treated as a source of information about the central nervous system. It is well known saying the eye is a window to the brain, but it's also a window to the whole body. This is the book we published on this topic already nearly 10 years ago. This is one of the recent studies showing that the AI model that was trained based on the fundus pictures was able to detect Alzheimer's disease with a very good performance. As you see, accuracy over 83% and sensitivity over 93%, specificity over 82%. So just an example, this is a fundus picture, and using AI model, we can say that this is the man. He is 67 years old, non-smoking, and without diabetes. He has body mass index of around 24 and a blood pressure of 120 to 85 mercury millimeters. There are also many different models that support the diagnosis or exclusion of different eye disorders. So we can also say that this patient has no diabetic macular edema, no retinal venous occlusion, no AMD, glaucoma, retinopathy of prematurity, myopic macular degeneration, macular hole, epiretinal membrane, optic disc edema, optic nerve atrophy, central serous retinopathy, retinitis pigmentosa, cataract, any refractive error, and either arteritic ischemic optic neuropathy or non-arteritic ischemic optic neuropathy. We also can exclude Alzheimer's disease, Parkinson's disease, stroke risk, risk of a heart attack, systemic hypertension, chronic kidney disease, peripheral arterial disease, anemia, hepatobiliary disease, and sarcopenia. So today, fundus picture can be used for a diagnosis of eye disorders, central nervous system disorders, systemic disorders, as a source of demographic data, including sex, age, race, and certainly this list will be with every year longer and longer, and it will be continued. As it is shown at this slide, on the left side we see number of ophthalmic disorders, on the right side we see the number of non-ophthalmic disorders that can be diagnosed today based on the fundus picture AI models. If you are interested in this topic, I recommend you our book on AI in ophthalmology that was recently translated into Chinese, and also to become a member of our International AI in Ophthalmology Society. The membership is free, and we are interested in building a global network in AI in ophthalmology. Thank you very much for your kind attention.
Good afternoon. Thank you for having me here today. My name is Alexander Melendez Moreno, and I will be presenting a case titled Unraveling the Mystery, a Case of Pediatric Retinal Detachment. I have no conflicts of interest to present. The chief complaint of the patient is a 5-year-old female patient who had progressive vision loss of the left eye. HPI, the patient, she started to lose vision since 1 week ago, went to an outside ophthalmologist who discovered a rheumatogenic retinal attachment of the same eye and referred the patient to a retina specialist for further management. Past medical history, completely unremarkable, no ocular history as well, and overall a very healthy girl. On examination, her right eye was 20/20, her left eye was 20/80, her pressures were normotensive in both eyes. Her movements were full in all gazes, and there was no evidence of APD, and her pupils were reactive to light. Slit lamp exam found completely normal with no evidence of AC inflammation or pathology at the cornea or lenses. Here we have a photo of the left eye where we can see a hypopigmented epiretinal lesion located at the level of the macula. Also, we have a retinal tear at the inferior border of the lesion with the associated rheumatogenic detachment affecting the fovea. If we go to the supranasal side at the retina, we can also see a similar hypopigmented lesion at the level of the retina. And here we can see a associated vitreous attachment. We performed an OCT imaging which demonstrated a complete retinal attachment that affects the fovea. Another OCT imaging, but this time scanning the area of the retinal tear, where we can see a retinal flap with the associated retinal tear on OCT causing the rheumatogenic detachment. Here we have a B-scan of the posterior pole at the level of the macula, where we can see a endophytic hyperechoic epiretinal mass associated with a retinal detachment. The mass doesn't have any calcifications or any cystic lesions associated to it. This is an image of the supranasal epiretinal lesion, which has similar characteristics to the one located at the macula. Something that we wanted to highlight here is where we can see the vitreous detachment that is associated in this eye. Here we have a late phase FA, where we can see the epiretinal lesion supranasally, which stains without leakage. If we go to the temporal side of the retina, we can see diffuse leakage that is non-specific for any retinal pathology. Extensive lab workup was given to the patient, and also imaging was done with brain MRI and head and chest CT, which didn't show any intracranial lesions or thoracic lesions. At 2 weeks follow-up, the patient was given oral medications, which did not resolve the epiretinal lesions associated. Also, the patient continued with the rheumatogenic detachment, for which it was decided to take the patient to the OR for a pars plana vitrectomy for excision of the epiretinal lesion located at the macula, for silicone oil placement, for endolaser, and injected with subtenon's triamcinolone. Here we can see is that we're excising the epiretinal lesion located at the macula. Here we can see the detached lesion from the retina, and here we're putting a cannula so we can aspirate the lesion and take it to pathology for analysis. At post-op day 1, we can see the excised epiretinal lesion at the macula and the laser that was given to that same area and also to the epiretinal lesion located supranasally. Pathology report demonstrated a fibrous nodule with mixed inflammation composed of plasma cells and eosinophils. And on the deeper sections, where we can see here, in this area with the arrow, we can see non-necrotizing granulomas associated with multinucleated giant cells. There was no evidence of any organisms related to this lesion. The labs were remarkable for positive Toxocara IgG titers and CBC with peripheral eosinophilia. The medications the patient received was albendazole due to possible toxocariasis. I would like to give the acknowledgements to my program director, Dr. Victor Villegas, and also to my mentor in the Cleveland Clinic, Arun Singh, and also everybody here today for giving me this opportunity for presenting this case. Thank you.
Yeah, thank you very much for this beautiful session, and I would like to thank Professor Grzybowski, who collected brilliant cases for this nice online meeting. We all have our duties, but I'm grateful for your time that you came here and listened to very extraordinary, partially cases that we, for example, in Europe do not see every day. So the panel is open to discussion. We have, I think, 10 minutes to discuss the cases.
Okay, maybe I start as a co-moderator. I have a question to Andrzej, because you are very much involved into artificial intelligence. Do you think that this kind of devices can substitute, for example, for our work in qualification for eligibility to anti-VEGF treatment, finally?
Well,
I would not like to, let's say, dominate the session with AI. It is very often because it's a hot topic. But yeah, I think that, well, the question is when, but certainly AI will support us significantly. As I mentioned, I'm not sure if it will happen next year or in 5 years because many of these tools are under development. And of course, we see the versions. They are changing, they are improving, and we still are not satisfied with the previous version and the present version. We hope that the next version will be much better. So there is, let's say, a course of the improvement. But yes, I'm pretty sure that in many applications, as I mentioned in my short, let's say, presentation, this is the list of already the available disorders to be detected, both eye and non-eye, like it's, let's say, neurodegenerative or systemic disorders, based on, for example, eye picture, just fundus photo. If we add to fundus photo OCT, for example, as the another image, to the multimodal, let's say, way, then we increase the performance very often of the model. More we add, more information, we can increase the performance. This is now the another tendency to use different sources of information in such a model. So yes, I'm pretty sure that well, maybe in a few years we will be able to use these tools, for example, to better predict individual needs of patients regarding anti-VEGF treatment or any other sort of treatment, possibly. Yeah.
Okay.
Great. I would like to ask Maciej Gawecki. This was a very interesting case, challenging case, and more often we see the patients with the older patient who have some kind of subretinal, sub-RPE deposits, and we are not sure if this is classical AMD or something else. So sometimes these diagnoses could be confusing. And you showed us also the nice pictures of ICG and OCT angio. And just this is my comment and my experience. I do believe that these leakages that we try to, with which we try to explain the formation of the subchoroidal, subretinal, sub-RPE deposits, that these leakages are not always continuously active. So I think that they could be active for some time, cause the problem, and then these deposits form, and we don't know how to get rid of them. And then when we start to perform the diagnosis, we cannot see them because they are inactive. Can you comment on this suspicion?
Yes, I agree fully, and I think that ICGA is absolutely necessary tool. It's not used that often, but it can solve us a lot of problems. And in fact, we with Andrzej, we published this case, and well, my concept also is that the reason, the origin of this kind of image is the choroidal depression. We usually know the foveal choroidal excavation from the pachychoroid spectrum of diseases. However, in this case, I think it's the curvature of the sclera that is a little bit different. And well, we plan, in fact, together to look at the much bigger cohort of the patients with AMD who in Poland are treated in our national program. And maybe we can, we can outline some kind of schemes, a kind of algorithm of how they behave depending on the shape of the choroid and shape of the sclera. located underneath the choroid. So I think it's pretty fascinating case because it's non-exudative, I'm sure. But I have also a question to the doctor from Nepal about the exciting moth problem, which is quite similar to Silence of the Lambs, I think, a movie. So what is the percentage of vitrectomies that you have to perform in cases like that? Is it frequent? Is it very frequent that you have to perform surgical treatment?
I'm not sure that Dr. Karki is here, or
Oh, he's not here. Oh, okay.
I'm sorry, I was going to ask him as well. Very interesting case presentation, and still with a different origin of the endophthalmitis or posterior uveitis, panuveitis, we still have the same methods of treatment, which he showed the conservative treatment, then injection, and the third severe grade vitrectomy. And this is very interesting just to know what are different causes of these panuveitis or endophthalmitis are in the world in the different countries.
Right.
Yeah, let me say a comment because it's a great pity that Dr. Pratap Karki cannot be with us. It's always some problem with the online meetings that we cannot really predict who will be able to connect and with the quality of connection. That's why we record all talks to be sure that there will be no problem during the presentation. But I would like also to remind our attendees that they can ask questions in the chat. And we are waiting during the whole conference, we are waiting for your questions, and moderators will check the chat and me also, and will process your, let's say, questions. And the second, as Maciej mentioned, we published this case, and today it's not very easy because not so many journals accept case reports. We are today during case reports meeting, but I can recommend you one of the journals. I'm the ophthalmic editor of Helion Journal. This is a relatively good journal. It covers all medicine, not only ophthalmology. I'm the ophthalmic editor, and they accept case reports. So if you have any interesting case report, you can consider this journal. It has, I think, impact factor, I don't remember exactly, but probably between 3 and 4. It is in PubMed index, so it's a good journal. And one of the few you can really publish your case report. So consider that. Yeah, thank you.
Okay. So we do not have any comments on chat, so I don't know.
And no more questions as I see. So let's have a short break now, and then we can move to the next session. I see that the moderators for the next session are ready already. So we can move into the next session after the short break. Thank you.
Thank you.
Thank you very much.
Thank you very much. Thanks.
I'm asking these questions. Why did it happen? What to do next? My really weird clinical cases. The first one, there is a patient, 50-year-old male, treated for primary open-angle glaucoma since 2015 on 3 medications. He had full visual acuity. His right eye pressure was 40, left eye 38, on 3 medications, both eyes. So in 2017, we decided to do micropulse cyclophotocoagulation. We did it twice, and twice SLT was done with no effect whatsoever. And in 2021, in April and in May, patient was referred to the glaucoma clinic we cooperating with, and they did trabeculectomy with adjustable sutures with mitomycin. And after healing process was done, his postoperative IOP, both eyes, dropped to 8 to 10 and no medications. Everybody were happy. In 2023, in November, this patient came to us with the IOP still 8 and 9. His visual field was as it's shown, but his best corrected visual acuity was 0.4, and so as you remember in the beginning was 1.0, and after trabeculectomy was 0.8. Right now it is 0.4 with plus lenses, the same to the left eye, a little bit less plus, but still. You could see that the hole here, you could see here in the OCT of the anterior segment that his angle was a little bit narrowed, and the nerve was a little bit more glaucomatous than it was before. Here is, as you see, the fundus photo in the right and the left eye. The left nerve is a little bit more damaged than the right nerve, and there are hypotenuse choroidal folds visible in the macula. And we could confirm these folds also on the macular OCT. So based on these information and we did even biometry, but my question is what to do. Cataract surgery, there is a little bit of cataract, but not a lot, but there is very low pressure, maybe compression sutures, and maybe both, and I am open for other suggestions. The next case, this was the patient who had a trauma that was perforation with cataract in 2013, so it was like more than 10 years ago. Primary operation after suturing the wound, that was phaco-vitrectomy in the left eye, and since then mydriasis is present and decentered IOL slightly down. Best corrected visual acuity in a year 2022 was 0.4, and he showed up in November 2023 with deterioration of vision to 0.1. Here is his fundus photo. I was a little bit suspicious of the macula, so here is also a red-free photograph indicating the macular edema, And we did OCT, and here it is. It's not only intraretinal fluid, but it was also subretinal fluid. The pressure was low. So we decided, okay, let's do triamcinolone injection as we did. The left picture of the OCT is right after injection, and it was going down as the edema was going down, as you see in the picture to the right. But we had some pressure problem because his pressure right after triamcinolone was very high. Here again, this is the evolution of this edema until complete resolution in from November to 2023 to February 2024. His visual acuity went back to 0.3. And post triamcinolone injection and IOP stabilization, best corrected visual acuity is 0.25, 0.3. But what to do if this edema reappear? You can see that there is still some intraretinal cysts. Any management? Maybe we should extract this IOL. Maybe there is an atypical uveitis glaucoma hyphema syndrome with no hyphema, post-injectional glaucoma, and only the recurrent edema. And remember that I can't give him again triamcinolone because this pressure right after was very, very high. I will be more than happy that if you can give me some comments, any questions, any remarks. Here's my email. I am very sorry if I am not available today because I have some problems with the internet connection, and I'm grateful for Professor Grzybowski for the invitation.
Good morning, dear colleagues. Today I want to present our clinical case about neovascular glaucoma associated with diabetic retinopathy. So it was a patient, 32 years old, insulin-dependent type 1 diabetes mellitus, blood glucose level 9 millimole, and glycated hemoglobin levels about 7 and 5%. Diagnosis: proliferative diabetic retinopathy, recurrent vitreous hemorrhage, diabetic macular edema, secondary neovascular glaucoma of the right eye. Non-proliferative diabetic retinopathy, diabetic macular edema of the left eye. Anamnesis: 4 injections of anti-VEGF to both eyes every 4 weeks due to diabetic macular edema. In August 2023, we performed pars plana vitrectomy due to recurrent vitreous hemorrhage plus endolaser panretinal coagulation. Visus was 0.4 logmar and intraocular pressure was 17 millimeters on brinzolamide plus timolol after surgery. On December 2023, we performed phacoemulsification plus IOL of the right eye. And 14 days after surgery, we performed the injection of anti-VEGF due to neovascularization of the iris and the anterior chamber angle. And we can see on the photos the full reduction of new vessels of the iris and on the anterior chamber angle. Visus after surgery was 0.1 logmar and intraocular pressure on brinzolamide plus timolol 24 millimeters. Over a month, we adjusted the patient's hypotensive treatment. The pressure increased periodically, and we added brimonidine twice a day and acetazolamide every day. Acute angle-closed glaucoma was on January 2024. After 1 month, our treatment. So objectively, swelling of the cornea, rugosis of the iris, and the anterior chamber angle. The pupil is dilated in diameter, and visus was 0.3. Intraocular pressure on maximal hypotensive therapy was 38 millimeters. And we performed corneal paracentesis and intravitreal anti-VEGF injection, but intraocular pressure was not compensated. It was 28, and on the next day we performed trabeculectomy of the right eye. After surgery, on the 7th day, this visus was 1.0 logmar, and intraocular pressure without any hypotensive treatment was 16 millimeters. On February 2024, visus was 1.1 logmar, but intraocular pressure increased to 35 millimeters. So we performed intravitreal anti-VEGF injection plus revision of the filtration path after 5 days of injection. And after surgery on the 7th day, visus was 1.0 logmar, and intraocular pressure was compensated, was 19 millimeters. On March 2024, visus was 0.4 logmar, and intraocular pressure was 40 on maximal hypotensive therapy. So we decided to perform transscleral cyclophotocoagulation of the right eye. And next day after the procedure, intraocular pressure was 7, and we cancelled all hypotensive therapy. On April 2024, visus was 0.3 logmar, and intraocular pressure was 11 without hypotensive therapy. And it is very important that on April 2024, an insulin pump was installed for the patient, and the blood glucose was in control. May 2024, June 2024, until now, the patient has a good vision, 0.1 logmar, and intraocular pressure is compensated 16 millimeters without no hypotensive treatment. Conclusions. It is very important to control intraocular pressure with patients of neovascular glaucoma. However, it is equally important to control and treat the underlying disease causing the development of neovascular glaucoma. So, thank you for your attention.
Dear colleagues, I would like to present clinical case mysterious papillophlebitis. A 42-year-old man came to our clinic complaining of a spot in front of his right eye for 3 days. He previously recovered from COVID-19 disease 3 weeks ago. His left eye was operated due to a traumatic cataract about 10 years ago. He had no previous medical history. At initial examination, best-corrected visual acuity was 0.0 logmar in the right eye and 0.0 logmar in the left eye. The intraocular pressure of the right eye was 18 millimeters of mercury and the left eye 19 millimeters of mercury. The anterior segment of the right eye was unremarkable. Slit lamp examination showed on the right fundus optic disc swelling, retinal venous dilation and tortuosity, peripapillary flame-shaped hemorrhages, and intraretinal hemorrhages along retinal vessels. You can see the fundus photo of the right eye at first presentation. Optic disc osity showed increased thickness of peripapillary retinal nerve fiber layer. We also performed visual field testing of the right eye, and visual field testing showed increased blind spot and decreased general sensitivity. The patient returned for examination in 5 days. Best corrected visual acuity of right eye was still 0.0 logmar, but during fundoscopy we noticed increased number of intraretinal hemorrhages and more significant optic disc swelling. Optic disc OCT also showed negative dynamic, but the macula was still normal. We referred the patient to the neurologist and cardiologist for additional testing and examination. Laboratory testing, including coagulation testing and serum autoantibodies, were normal. Brain MRI was normal. Any systemic diseases, including vascular diseases, were excluded. How about diagnosis? The patient was diagnosed with papillophlebitis. There is significant mismatch between best-corrected visual acuity and fundus findings, which is typical for papillophlebitis. Any systemic diseases were excluded, and younger age is usually not associated with ischemia. How about treatment? Because of the negative dynamic on fundus of the right eye and optic disc OCT, we decided to prescribe treatment. The patient was started on oral prednisolone 1 mg per kilogram daily and acetyl salicylic acid 100 mg daily. After 4 weeks, the patient complained of decreased vision of the right eye. The best corrected visual acuity of the right eye was 0.18 logmar, and the macular OCT showed macular edema. What to do? Intravitreal injection. Intravitreal injection of aflibercept was done. On 4th week after intravitreal injection, best corrected visual acuity of the right eye was 0.0 logmar, and macular edema completely resolved. Optic disc swelling of the right eye also gradually resolved, and during further observation, no recurrences were observed. Papillophlebitis is still a mysterious and rare disease with ill-defined pathogenesis and lack of evidence-based treatment guidelines, but with favorable prognosis. COVID-19 disease can be one of the causative factors of the papillophlebitis. Thank you for the opportunity to present my clinical case.
Dear Chairman, ladies and gentlemen, I would like to present the findings of our analysis conducted at the first department of ophthalmology of the Pomeranian Medical University in Szczecin, headed by Professor Anna Machalinska. In a healthy macula, the layers of the retina remain intact, ensuring clear vision. When full-thickness macular hole occurs, the entire thickness of all retinal layers is lost in the macula's central area, leading to a significant decrease in visual acuity. The standard treatment for full-thickness macular hole is pars plana vitrectomy. For patients with coexisting cataracts, the question arises whether to perform both surgeries simultaneously, phaco-vitrectomy, or would it be preferable to stage the cataract surgery and PPV separately over time? The first patient is a 76-year-old woman. At the first visit, visual acuity was 0.2 with correction. An OCT examination measured the whole dimensions, 225 micrometers at the narrowest point. The patient was scheduled for cataract surgery, which was performed 1 month after the first appointment. 1 month later, an OCT examination showed a reduction in macular hole size, along with observed vitreomacular traction. Two months later, tissue bridging and the presence of subretinal fluid were observed. 4 months later, the macular hole fully closed, and fluid resorption occurred, with visual acuity also improving to 0.6. After spontaneous hole closure, the multifocal electroretinogram showed a significant improvement in P1 wave amplitude density in all rings, though implicit time in ring 1 was prolonged. Microperimetry examination showed improvement in macular sensitivity and fixation stability. In light of this case, a question arises. Does the dynamics of spontaneous closure of FTMH vary among different patients, or does it typically follow a consistent timeline? Our second case is 74-year-old man. At the first visit, visual acuity was 0.4, and OCT measured the hole at 405 micrometers at the narrowest point, along with the presence of an epiretinal membrane. The patient was scheduled for cataract surgery, which was performed 2 weeks after the first appointment. Follow-up visits showed a gradual reduction in hole dimensions. 4 months later, tissue bridging began and subretinal fluid was observed. At follow-ups 5 and 10 months post-surgery, the macular hole closure process continued. 13 months after the first appointment, complete macular hole closure and subretinal fluid resorption occurred. Visual acuity was 0.5. Similar to the first case, after spontaneous macular hole closure, the multifocal electroretinogram showed significant improvement in P1 wave amplitude density in all rings. Though the implicit time was prolonged. Microperimetry after FTMH closure showed improvement in macular sensitivity and fixation stability. Does the probability of spontaneous closure of FTMH depend on the size of the macular hole? Our final patient is 67-year-old man with hypertension and type 2 diabetes. At the first visit, visual acuity was 0.3. An OCT measured the macular hole at 342 micrometers at the narrowest point, with the presence of an epiretinal tissue proliferation. The patient was scheduled for cataract surgery, which was performed 1 month after the first appointment. 2 months later, an OCT showed a reduction in hole size. A month later, tissue bridging and subretinal fluid were observed. 4 months after the first appointment, the FTMH had not yet fully closed, and subretinal fluid was still present, though visual acuity improved. The patient remains under further monitoring for complete closure. As with the previous cases, after spontaneous hole closure, the multifocal electroretinogram showed significant improvement in P1 wave amplitude density in all rings, though implicit time was increased. Consistent with other cases, microperimetry showed improvements in macular sensitivity and fixation stability. For FTMH patients qualified for vitrectomy surgery, it is essential to regularly monitor macular hole dimensions. Special attention should be given to assessing these parameters immediately before surgery to avoid unnecessary surgical interventions. It is worth emphasizing that for patients with FTMH, separating cataract surgery and PPV over time may be beneficial. Thank you for your attention.
Hello, my name is Noor. I am a resident doctor in the UK, currently rotating in an ophthalmology department, and I will be presenting this case to you all. So this is the case of a 65-year-old lady who has a past medical history that includes a history of 26 years of diabetes mellitus controlled with tablets and insulin, hypertension, asthma, hypercholesterolemia, and a history of 16 years of hearing loss. So our patient presented to the diabetes screening for a routine eye check, and she didn't report any issues. She was seen by the optometrist. When they were examining the investigations from the period, the OCT from the period from 2021 to 2023, they found that there was isolated excessive thinning of the retinal layers that was visible over that period. All other findings were unremarkable. Visual acuity wasn't affected. Visual fields were all clear. Normal pupil response, no flashes or flashes. The optometrist did a fundoscopy examination, and they found patches of thinning looking like thyroid fundus. They became concerned, and they referred urgently to ophthalmology to understand what was happening and to get a second opinion to rule out malignancy. On her visit to the eye clinic, our patient was still asymptomatic. She was seen by a consultant ophthalmologist. Her visual acuity was fine bilaterally. The investigations and clinical examinations showed retinal thickness in both eyes was preserved in the foveal area. However, the perifoveal area was overall measured and measured less than 250 microinches. Then the OCTV scan in both eyes, this is the right eye, but in both eyes it showed foveal areas relatively spared, but parafoveal areas were atrophied and thin. And this is the left eye. Then we did fundus imaging, which showed retinal atrophy, specifically parafoveal areas, and areas of RPE thinning. So that this is what it showed. On slit lamp biomicroscopy, the cornea was clear, there was non-significant cataracts, and on fundoscopy, it confirmed the previous investigation's findings, patchy retinal atrophy, and thinning of the retina with spared fovea. So getting to the diagnosis, and we recap the history with the patient, which we didn't mention before. Patient had a history of mitochondrial disease with a known mutation diagnosed around 10 years ago, and when she was genetically tested. So given the findings of retinal dystrophy and patchy atrophy, this was suggestive of mitochondrial retinopathy, and the plan was to review the patient in 1 year, or if she develops any new symptoms, it was to see her earlier, like developing vision changes, blurred or distorted vision, especially in central vision, and in some advanced cases, patients may have significant vision loss. So maternal inherited diabetes and deafness. This is the condition, which happens as a result of a mutation in mitochondrial DNA. It's a multi-system disorder characterized by diabetes and sensory neural hearing deafness. So most cases are caused by this mutation, which is an A to G transition identified at nucleotide 3243 in the mitochondrial gene for encoding this transfer RNA. Sorry. And depending on the mutant load and tissue level, can present heterogeneously clinically. So it can present as MIDD or mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episode syndrome, or an overlap syndrome. So given it's the genes involved in these conditions are found in mitochondrial DNA, this condition is inherited in mitochondrial pattern, which is also known as maternal inheritance. Yeah. So mitochondrial diseases arise from the dysfunction of the mitochondrial respiratory chain. And the same genetic variant can cause different clinical presentations depending on the level of tissue mutation load, which is a unique characteristic of mitochondrial diseases. So within a same cell, the pathogenic mitochondrial DNA mutations are frequently mixed with normal mitochondrial DNA. This is known as heteroplasmy, and as the percentage of the mutant copies or load increases, there will be increasingly severe defect, bioenergetic defect, causing more severe clinical presentations or a wider spectrum of clinical presentations. So the diabetes, in our case, in this condition, often goes misdiagnosed as type 1 or type 2 diabetes. In our patient, it was firstly diagnosed as type 2. Initially, she was only on tablets, but she was then she needed insulin therapy. So this is what happens usually with these patients. And then when she was genetically tested, it was labeled as rare monogenic diabetes and routinely followed up by the endocrinology team. So deafness in this condition is also very common. 75% with these patients happen. And it's in the case of our patient, it was for 16 years, and she was using in the canal hearing aids, and she was being followed up by the ear, nose, throat team. And retinopathy, we have a gradient system established by the LAT, and given the retinal abnormalities in our case, can be labeled or classified as grade 3, given there is multifocal perifoveal atrophy of the RPE. Yeah. So family history, which we couldn't disclose before, our patient had only one daughter, and at the time she was genetically tested, her daughter was also tested, and she was found to be a carrier of the same mutation and also started to be affected. So the patient told us that the mother and close relatives to her were not affected and were not tested. But it is important that a definite genetic diagnosis is made to confirm the cause of the deafness and diabetes, which will help with treatment decisions or follow-up and management decisions and helps advise other members of the family. So given the broad phenotypic expression, even between individuals of the same family, some of them may develop symptoms, some of them may not. So, and just be carriers. They were both followed up by the mitochondrial diseases team and by these different specialties routinely. So this mutation can cause different clinical presentations and syndromes. Maternal inheritance can leads to a heteroplasmic genotype, which can lead to potential diagnostic obstacles and a diverse phenotypic expression. Family history of diabetes, deafness, and retinal dystrophy can be suggestive for genetic testing and lead to different investigations. And currently, there's no specific pharmacological treatment for mitochondrial retinopathies, but those with advanced symptoms or disease involving the fovea or with chorioretinal atrophy can benefit from supportive management, visual impairment, registration, and referral to low vision clinic. And this is all. Thank you very much for your attention.
Thank you to the good presentations of all the 5 speakers. Steve, do you have any question for now? Any
My
questions?
fault. Sorry, I'm muted. Much better. The second talk, Dr. Sidorchuk. Are you there? Great, thanks. I enjoyed your case. I maybe I missed it. I only saw one fundus photo, and I didn't see a lot of photocoagulation in the periphery.
Yes, we did photocoagulation and laser photocoagulation during pars plana vitrectomy.
This is one of my pet peeves, actually. I'm glad you did that. I think in general, we're all, me included, we're all using a lot of anti-VEGF to treat our diabetic patients, and I think we're underutilizing laser. And there's a trap that you can fall into, because I've fallen into it many times, where patients doing well with anti-VEGF, and then for whatever reason you extend an interval or skip an injection, and then the eye goes into neovascular glaucoma, and you have a very serious problem. So I think it's hard to manage neovascular glaucoma without hammer photocoagulation. But obviously your case did terrific, particularly after the patient started systemic insulin. Thanks.
Thank you so much. Yes. Yes, we have our algorithm of treatment of neovascular glaucoma, and this case is unstandard actually, because we performed all type of treatment and laser coagulation and anti-VEGF treatment, surgery, revision of the filtration pass, and only after cyclophotocoagulation. So in standard cases, we use hypotensive treatment, laser coagulation, and anti-VEGF. It depends on stage of neovascular glaucoma and level of intraocular pressure. So this was unstandard situation.
Thanks.
Okay. I would just like to say that I agree with Steve that the use of laser photocoagulation for diabetic patients is really getting lower and lower. But as much as possible, I think let us always remember that prevention is the key. So in my patients, if they have diabetes for more than 10 years, I would really try to look for any signs of what you call ischemia, even though we're used to using OCTs to look at the macula. But we also should always remember that the macula is one problem, and we also take a look at the peripheral areas.
Yes, of course, I agree with you. Thank you.
If we have some time, I'd like to talk a little bit about the first case with hypopnea maculopathy. I found it very interesting, and one of the questions was whether to do cataract surgery in combination with compressive sutures. Unless there's some significant cataract there, I would go straight for compressive sutures. Use the Palmberg technique. It usually works very well. Leave the pressure at the end of surgery slightly higher for the first few days, even if it's, of course, not too high, but for a few days to help. I've seen that it helps accelerate the process. But the cataract surgery, I think we'll just add another confounder there and wait much longer before I do anything there.
All right. fifth speaker about mitochondrial disease, because I don't think we have it here in Asia so much. This Dr. Alam Norel Huda. Is she around?
Hello, yes, I am around.
Okay, good.
Thank
No,
you.
because I'm just curious, like, usually in these cases, in your patient, what would you expect that would happen to the eye in the next, let's say, 5 years from now, perhaps?
So it varies. It depends on the patient really, and on the as we were saying during the presentation, it depends on the mutant load. So they, depending on that percentage of mutant load, they can develop more serious or more severe clinical symptoms, and that retinopathy, for example, might go and worsen over time. But for example, our patient, we've been following her up. It hasn't been that long. We just started. We saw her a year back, and the retinopathy is stable. So we don't really know how it will progress in the future, and there's not much like literature about exactly what to expect. So not really. She's being followed up by different specialties, multidisciplinary, just to catch the symptoms or clinical manifestations earlier. Yeah.
Okay, thank you.
Can I make two brief comments on that case? I enjoyed the case. I thought it was a terrific presentation. First comment was, and it's difficult because I don't think we can put the OCT image back up again, but the OCT had preserved the inner segment, outer segment layer in the center. It preserved the ellipsoid, and then the ellipsoid went away nasally and temporally, which corresponded to the areas of atrophy. Well, in other contexts, that OCT pattern is called a flying saucer, right? Such as what you would see in hydroxychloroquine toxicity, but it's broader. It doesn't look the same.
Okay, thank you.
And I think that other inherited retinal dystrophies give you that pattern where you have a flying saucer, but it's not just the very center of the image. It's most of the frame, and then the atrophy, the dropout of the ellipsoid zone is more peripheral. And I think that's a kind of something you can look for. And then my second question is more for the group than for you, but does everybody on this call have access to genetic testing for inherited retinal diseases?
So in the NHS, usually, yes. So depending on, of course, on your suspicion and everything. I was yesterday in a conference where they were mentioning the access to genetic testing. So usually if we have a patient that comes in with features that we think are part of a genetic syndrome, we can refer to the genetic team. And yeah, if we are suspecting that, they can get access to genetic testing. But of course, it needs to be highly suspected, not any person just get. But privately, that's allowed. But if it's through the NHS with the National Health System, it needs to be highly suspected. But we, as ophthalmologists, we can refer to them. Yes.
In the US now, we have access to essentially free genetic testing that's done by various labs. So we're doing more and more of this. And we used to spend a lot of time learning the different patterns on fundus photos and autofluorescence. But really, the diagnosis now is genetics moving forward.
Yeah, so in the UK, as like the 100,000 genomes project, so it's trying to be extensive and accessible to more people now. But yeah, it needs to be like suspected clinically and then referred to the genetic testing team. Thank you very much. Thank you.
I can contribute to the genetic testing that we are still in our infancy stage. So I think over time, maybe in the next 5 to 10 years, we'll be having more fellows going to genetics, but I think right now we only have 2 or 3. Any more questions from the audience, perhaps?
About the fourth case, Dr. Zaraska? Are you here? That was the macular hole closure cases. Maybe now I like those cases too. Spontaneous macular hole closure is, always sort of interesting when that happens. It's possible that the macular holes that are associated with inflammatory disease rather than idiopathic macular holes are more likely to close spontaneously. We know that the traumatic macular holes are more likely to close spontaneously. But I published a case a few years ago of a patient being treated for cancer with an agent called nivolumab, which is Opdivo in the U.S., which is a highly inflammatory drug that can cause inflammation in any body part, including the eye. And the patient had uveitis, cystoid macular edema, and a macular hole. The drug was stopped, the hole closed. And actually the hole reopened and closed a second time at another point. So the macular holes that are more likely to close without surgery are again probably the ones secondary to trauma or to some inflammatory condition.
Okay, this is very interesting comment. Yes, but in our cases, they were idiopathic macular holes. So we excluded any signs of inflammation, uveitis, and so on. So they were just ordinary cases of idiopathic macular holes. Thank you.
Sure, that's great. There's a growing trend in the U.S. to treat some macular holes with topical agents. So sometimes it's a combination of topical prednisolone acetate, a non-steroidal like ketorolac, and sometimes dorzolamide. And there are, a few small case series of positive results for this, but you have to wonder if it's really the treatment or if it's really spontaneous closure of the macular hole.
Yes, it's very, very good comment. Thank you very much. Yes, of course, I think that triggering factor that we would suspect, of course, would be the cataract surgery. Yes, because in all those 3 cases, the cataract surgery was performed before hole closure.
So was there a posterior vitreous detachment prior to the cataract surgery?
Yes, we haven't noticed any connection between VMT, vitreous detachment, and closure. In one case, as we shown, the VMT was already present at the beginning. Yes, in one case, the epiretinal proliferation was present. So it was the degenerative origin of the hole. And in one case, maybe a little bit of epiretinal membrane. So the origin was variable. Yes, we cannot say that the closure was a result of detachment of the vitreous body from the macula.
Thanks. Yeah, in the U.S., we used to have an approved agent called ochraplasmin. I don't know if that ever got approved in Europe, but it was a European company that made it. And ochraplasmin was a one-time intravitreal injection that could induce a posterior vitreous detachment in maybe half of patients, and sometimes it could close a macular hole.
No, we don't have any experience with this agent. Yes.
It was very expensive. There was a small rate of retinal toxicity with electroretinographic changes, and I don't think you can get the drug anymore.
Good. Everything's good.
If we have a little more time, I don't think we discussed the third case, which is Dr. Tomkiv, the papillophlebitis.
Oh, yeah, I think we should. Okay. The papillophlebitis.
I enjoyed that case too. How do you tell papillophlebitis from a mild central retinal vein occlusion?
Sorry, could you repeat the question?
How do you distinguish papillophlebitis from a mild central retinal vein occlusion?
In this, in case of central retinal vein occlusion, I think we will have a decreased vision and probably more vasculopathic factors like hypertonic disease, atherosclerosis, and others, and probably older age of patient, I think.
Thanks. You sometimes see retinal vascular occlusions in retinal vein occlusions in younger, healthier people. And I guess we have to wonder if we're misdiagnosing what are really papillophlebitis cases.
Maybe more involvement of the optic nerve.
Yeah.
Because in this case, he present with optic disc swelling and peripapillary hemorrhages, and later we saw more hemorrhages along retinal vessels, and the swelling also became more significant.
Your patient, if I remember correctly, you treated initially with oral corticosteroids, and then
yes,
and then followed up with anti-VEGF. So I guess that's an interesting question also, is which is more invasive, right? Which has more potential toxicity to a young female patient? Is that your usual protocol when you see these patients, is to go with prednisone and milligram per kilogram per day?
Sorry, I don't hear.
Oh, I'm sorry. Maybe I'm not clear. What I remember from the report is you initially treated with oral steroids, 1 milligram per kilogram per day for several weeks. Is that correct?
We treat him for 2 weeks, and then we slowly taper the dosage.
Right, and in the patient you showed, the edema recurred and you treated with anti-VEGF. Is that correct?
In this case, we suspected some ischemic factor, and we thought to do, because of the macular edema, to do some intravitreal injection. We consider anti-VEGF or maybe corticosteroids, but we don't often use intravitreal corticosteroids because we only have triamcinolone for intraocular injection, and in case of corticosteroid intraocular injection, we have a risk of increased intraocular pressure and cataract formation. So we prefer to use anti-VEGF treatment.
Thank you.
I have additional question, may I? Yeah, have you considered subtenon injection of triamcinolone?
No, in this case, we did intraocular injection. I saw several patients with macular edema due to another cases, and we performed subtenon injection of triamcinolone, but I haven't seen any result. So in this case, we prefer intraocular injection of anti-VEGF.
You performed the subtenon injection with subtenon cannula or just injected with a sharp cannula?
We perform with cannula, yes.
Okay. Can I contribute something? As far as triamcinolone injection, whether it's especially when you do it subtenons, and sometimes even with intravitreal, as long as if it's subtenons, I am not afraid of increase in ocular pressure. But I always tell my patients within 2 to 3 weeks, if they have an ocular rise, they should start with alphagan or bimodidine tartrate. I'm not afraid of that because usually after 6 weeks to 8 weeks, the effect of the medicine starts going down. The half-life is really, really fast in 3 weeks. So in these cases, that I would also think that doing the intravitreal injection like anti-VEGF would be my last step. At least I have something else that to use later on if there's a recurrence. And at the same time, if there is an intravitreal injection and there's a cataract formation, the best approach, if you're going to use it in other patients, maybe for macular edema, is that you always have to counsel the patients first and try to select them very well. So, I mean, just to help you with the process. And we have one more question. If anyone, could you comment any investigation of treatment of central macular edema after trauma in the second case? Is a question from the audience? On the chat box. Any more questions, perhaps? You see, can you read in the chat box? There's a question.
Yeah,
Yeah. Yes, I think so far we are done. If there are no any questions, and thank you for the panel and from the other moderators for giving their inputs for this second part of case reports in Poland.
Good day, everyone. I am Marifel R. Montenegro from De La Salle University Medical Center. I will be presenting a case entitled All Eyes on Eyes. We have a patient FC, 33-year-old female Filipino single Roman Catholic from Cavite, Philippines, who came in with a chief complaint of blurring of vision of both eyes. History started 19 years prior to consult when the patient experienced blurring of vision with episodes of photophobia. She noted a whitish opacity on the limbal area of both eyes but did not seek consultation. 12 years prior, the patient visited an optometrist, was prescribed eyeglasses, and was advised to consult an ophthalmologist, but no consultation done. The patient reported that her relatives had noticed an unusual finding in her eyes, described as having a cat's eye appearance. Interval history, patient had progressive blurring of vision, described as intermittent, that spontaneously resolves during the day. Persistence prompted consult. For the past ocular and medical history, patient had been on eyeglasses for 12 years and is asthmatic. The rest of the past medical, family, and personal history were unremarkable. Review of systems and vital signs were generally unremarkable as well. On physical examination, visual acuities 2014 improved to 2032 plus 1 on the right, and 2025 improved to 2020 on the left. The IOPs 18 on the right and 16 on the left, with extraocular movements full and equal. For the first question, what are the abnormal findings seen in the patient, described as adhesion of the peripheral iris extending to the angles? Answer is A. Peripheral anterior synechiae. On slit lamp examination, both eyes have correctopia. Pupil is 3 to 4 millimeters in the right, while the left eye is 2 to 3 millimeters, briskly reactive to light with no RAPD. Iris atrophy are seen from 7 to 10 o'clock on the right, 4 to 7 o'clock, and 9 o'clock on the left. Whitish opacities near the limbus are seen in both eyes, accompanied by iridocorneal membranes encircling 360 degrees. The cornea exhibited a hammered silver appearance extending to the endothelium. Next question. Peripheral anterior synechiae can extend up to which anatomical structure in the anterior chamber angle? Answer is A. Schwalbe's line. Gonioscopy was done and revealed presence of broad peripheral anterior synechiae with obstruction extending to the Schwalbe's line on both eyes. Fundus photo of the right eye seen through a clear media is a red-orange disc with distinct disc borders with enlarged cup-to-disc ratio of 0.9 on the right and 0.8 on the left. Blood vessels are normal in caliper at 2:3 ratio. There is tortoise vessels seen at the inferior arcade, no hemorrhages and exudates with good foveal reflex. At this point, what diagnostics can we request for this condition? At the OPD, patient was referred to glaucoma and ED cornea service. Diagnostics were requested and patient was started on betaxolol eye drops 2 times a day on both eyes. Perimetry showed generalized depression with focal defect having a constricted tunnel central field in the right eye and superior arcuate scotoma in the left eye. OCT ONH showed RNFL thickness on the right eye at 50 microns with superior and inferior notching and 67 microns showing inferior notching on the left eye. OCT of the macula showed normal values in the macular region, and central corneal thickness is 454 microns in the right and 477 microns in the left eye. For the ASOCT, there is high pass with reflective tissue layer on the iris seen between green arrows more prominent on the right, with angles showing high peripheral synechiae pointed by orange arrows. Corneal endothelium appears to be continuous with reflective tissue layer on the surface of the iris pointed by the red and white arrows. Specular microscopy revealed polymorphism, polymegathism, and cells with indistinct borders in both eyes more prominent in the right eye. It revealed areas of endothelial cells containing hyperreflective nuclei. For the course of treatment, patient was maintained on anti-glaucoma medication and is being followed up, showing minimal reduction of pressure on both eyes with other unremarkable findings. Next question, based on the patient's history and physical examination, which of the following is true of the pathophysiology of this condition? Answer is B. Progressive proliferation and migration of corneal endothelial cells forming membrane-like structures. To further discuss, this condition is characterized by proliferative and structural abnormalities of the corneal endothelium, progressive obstruction of the iridocorneal angle, and iris anomalies. It is considered rare and typically present unilaterally. However, bilateral cases have been reported. It usually affects women between 2nd to 4th decade of life, but cases have been reported in younger patients. Based on the theory from Campbell, Abnormality of the corneal endothelium leads to formation of membrane across portions of the anterior chamber angle and anterior surface of the iris. Contraction of the membrane leads to peripheral anterior synechia and iris changes. Next question. Other clinical findings may present in this condition as D, all of the above. There are 3 types, each with characteristic clinical findings such as early and marked edema, full thickness hole, and iris nodules and atrophy. Next question, what are the possible long-term outcome of this case? So the answer is all of the above. Secondary angle closure glaucoma is a consequence of high pass but can at times occur with overt synechia because of the advancing corneal endothelium that can functionally close the angle without contraction. The corneal edema found in this condition is felt to be secondary to both elevated intraocular pressure from secondary glaucoma and from subnormal pump function from the altered corneal endothelial cells. Iris atrophy or hole formation can also happen. Evaluation of this case includes thorough history and comprehensive physical examination. And as for the management, it is subdivided into 3 categories. First is management of corneal decompensation and its related complications. Second is addressing its iris atrophy and its cosmetic and visually significant sequelae. And third is controlling glaucoma associated with the syndrome. For the prognosis, it is fair and dependent on timing of diagnosis with the disease course and the success or failure of treatment. So what is the final diagnosis? The final diagnosis is iridocorneal endothelial syndrome, essential iris atrophy variant with secondary angle closure glaucoma of both eyes. To conclude, ICE syndrome is a rare condition that may cause secondary glaucoma. Early identification is beneficial to initiate better management and avoid associated complications, and ocular findings confirmed through imaging are helpful in diagnosis and contribute to effective case management, monitoring disease progression, and preventing complications. Thank you and good day.
Thank you for the opportunity to present this case to you today. This is a 40-year-old white male with pigment dispersion syndrome in our practice since 2018, taking only timolol once a day in the left eye. History of Tmax of 30 in the right eye, 36 in the left eye since 2018. No significant medical history, no significant ocular history, and no family history of glaucoma or eye diseases. Clinical examination, 20/20 vision, pressures of 21 and 23 on timolol left eye, average central corneal thickness, angles open with increased pigmentation as would be expected in this case, anterior segment without any significant abnormalities, a deep anterior chamber with some transillumination defects, more in the left eye than the right eye, and the lens is clear. No changes in the vitreous, some cup disc ratio symmetry, with the left eye a little more cupped than the right, and wearing myopic prescription. These are the OCTs done in July 2021. You can see on the left-hand side the optic nerve scans showing a healthy retinal nerve fiber layer, and in the right, the ganglion cell scan showing a suspected inferior ganglion cell loss, which is not consistent with the optic nerve scan. This is the panel map combining disc and macula. You can see here that ganglion cell defect in macula is not replicated in the RNFL, so it's probably just an artifact. Visual fields, right eye and left eye, some scattered abnormalities, perhaps some superior defect going on in the right, a little more in the left. Because the patient had pigment dispersion, we did an anterior segment OCT. As you can see here, from that day, a significant bowing of the iris posteriorly, which has been described in pigment dispersion in the past. In February of last year, 2023, the IOP spiked to 30 in the right eye and 34 in the left eye. The patient exercised regularly and used a jackhammer for work and was doing it the day prior. So at this point, what are the treatment options? More drops, an LPI, or SLT? So the patient in February 2023 repeated the OCT. As you can see here, both the RNFL and the macula are unchanged compared to 2021. Visual fields actually got better, perhaps some learning effects. So no abnormalities consistent with glaucoma here. And the patient has been exercising regularly during that period. In March of 2023, we chose to do an SLT in the left eye. And as you can see here in the curves, even after the laser on March 2023, despite some pressure reduction, the patient still experienced spikes. And in November of 2023, he came with pressures of 22 in the right and 30 in the left eye. Again, only on timolol, left eye, and an SLT done a few months before. So at this point, would he benefit from laser peripheral iridotomy? That's a big point for discussion. So there has been extensive studies on the format of the iris in pigment dispersion using UBM. And it has been shown that in eyes with asymmetric PDS or pigmentary glaucoma, more posterior insertion of the iris with greater contact with the zonal apparatus in the eye with worse disease, suggesting that this anatomical abnormality may predispose to worse disease. It's also known that accommodation worsens this effect, worsening the bowing and the contact, which results in increased irido-lenticular contact and dispersion of pigments to the aqueous humor. There have been attempts to test whether a laser peripheral iridotomy is effective. This is a study by Gandolfi and colleagues that they compared, look at 10-year follow-up of patients who underwent LPI, comparing patients who did not have LPI and those with increased risk of developing elevated intraocular pressure during the follow-up. So well-conducted randomized clinical trial, here are the details. But the main conclusion from that study, as you can see here, is that if you look at the high-risk patients who underwent an LPI, they were less likely to experience pressure elevation, which was defined as an elevation of more than 5 millimeters of mercury during follow-up. Whereas patients at high risk experience a significant proportion of them the event of worsening in the IOP control, suggesting then that LPI would be beneficial in these patients. So going back to our patient, this is showing we decided to do an LPI for in the left eye, which was the worst eye. Here is the scan before that I showed you earlier, and after, still the same. So absolutely no effect of performing LPI, at least anatomically, in this patient. So it was chosen to change timolol to prostaglandin. In the left eye, the pressures have been around 22 millimeters of mercury, which are fine, but the patient every now and then still comes with pressure spikes. So what to do in this case? Should we keep adding drops to a patient who apparently does not have confirmed glaucomatous optic neuropathy? Would it even be the case of performing an incisional surgery in this patient to prevent development of the disease, given what we know about pigment dispersion and its risks? So this is a question that we are weighing, and we're following this patient. But so far, I just wanted to show that LPI, yes, has been shown to be effective, but not all patients may respond to it, and we may have to go back to our usual arsenal of therapies to prevent vision loss in glaucoma. Thank you.
Hi, my name is Michael Antonetti. I'm a fourth-year medical student at the University of Miami, applying into ophthalmology residency this cycle, and I'm excited to share our case on The Plaque is Back, a case of resistant ocular surface disease. And first, I'd like to thank my mentor, Dr. Carol Karp, for all of her support in this case as well. Our financial disclosures are below. And we'll begin with our case of a 36-year-old male patient referred to our institution for a second opinion of his corneal and conjunctival lesion in the left eye. In order to do a complete exam, the right eye vision was 20/20, the left eye was 20/40 with this epithelial opacity, and the IOP in both eyes was normal. Slit lamp examination in the right eye was completely normal. However, in this left eye, we see an epithelial opacity over the inferior 70% of the cornea, extending around 11 millimeters horizontally and 8 millimeters vertically on the cornea. In addition, this patient also had mild gelatinous thickening at the inferior limbus from the 3 to 9 o'clock position. Prior to seeking treatment at our institution, this patient was also biopsied in Mexico City, and that biopsy showed melanosis and calcification. And also, the patient was started on topical interferon alpha 2B 4 times per day for 6 weeks prior to presentation as well. And so that begs the question, is there something hiding there that we're not seeing? And so in order to come to that answer, we always do an anterior segment OCT on our patients. And so we did an anterior segment OCT on this patient, and it revealed a diffusely hyperreflective and thickened corneal epithelium, as shown with the white asterisk. There was no abrupt transition seen because the entire corneal surface was covered with the ocular surface lesion, and thus there is no normal cornea within this image. We did another anterior segment OCT a little bit more inferiorly, and that showed diffusely thickened hyperreflective epithelium with an abrupt transition as shown by the yellow star. And so before we reveal the diagnosis, this is a classical finding of one of the ocular surface diseases that we commonly see at Bascom-Palmer. And so I'd like to allow you guys a moment to think about what the diagnosis may be. And so if you guessed corneal intraepithelial neoplasia, you were correct. We conducted a corneal biopsy, and that revealed hypercellular pleomorphic lesion with demonstrable Ki67 staining up to full thickness and confirmed the presence of CIN. Interestingly, we also biopsied 4 limbal spots and 5 bulbar conjunctival sites, and these were all negative for malignancy. And so that brings us to our treatment options to treat OSSN. And so we can do surgical excision with cryotherapy, but we can also use topical chemotherapeutic agents like 5-FU, mitomycin C, and interferon alpha 2B, which is currently unavailable in the United States. And I'd like to point out a nice mnemonic that Dr. Karp came up with that she uses with our patients. And so we call mitomycin C El Diablo, which is the devil drop. We call 5-FU the little devil drop. And the reason we do that is because mitomycin C has the harshest side effect profile, and 5-FU has a bit milder of a side effect profile and is better tolerated by patients. And finally, interferon alpha 2B, which is currently unavailable in the United States, we call our angel drop because of it's so well tolerated by patients. So what do we do for our patient? We literally and figuratively threw the kitchen sink at this patient. So we knew this patient was treated with 6 weeks of topical interferon, but there was still disease when we saw the patient. And after that, we decided to start the patient on 4 cycles of topical 5-FU. And we gave this to the patient. We gave topical 5-FU 1% 4 times daily for 1 week, followed by a 3-week holiday, which is considered 1 cycle. And after 4 cycles of 5-FU, there was clinical improvement in the corneal disease, but there was still residual hyperreflectivity and epithelial thickening on the anterior segment OCT. For this patient, due to the diffuse disease involving 6 clock hours of the limbus, surgical excision was deferred in order to mitigate the risk of limbal stem cell deficiency. And so after we gave the 5-FU and we saw no response, we placed a punctal plug in the inferior punctum and gave the patient 2 cycles of mitomycin C. There was still multifocal disease seen on anterior segment OCT and clinically following his treatment with mitomycin C. So after that, we treated the patient finally with 1 injection of some conjunctival 5-FU, 25 milligrams. And what we saw was that there was no resolution of the disease. And I'll show you some pictures following those treatments where we can still see that there's disease present clinically. And as you can see on the right, it's even extending onto the cornea when you look at the inferior nasal slit lamp photos. And in addition, we see that there is positivity in these anterior segment OCTs as well, where we can see the diffuse thickening, the hyperreflectivity, and the abrupt transition that I'm pointing to here and here. So what should we do now for this patient? We've treated our patient with these topical chemotherapeutic drops, and we've already discussed that surgical excision with cryotherapy is not a good option due to the risk of limbal stem cell deficiency, so this isn't a good option. We've given the patient interferon, 5-FU, mitomycin, and even a subconjunctival injection, so this is not a great option. Now what do we do? So what we decided to do was treat the patient with a radioactive plaque. And we treated our patient with an 18 millimeter I-125 collaborative ocular melanoma study plaque with a 1 millimeter tumor apex dose of 50 gray over a 97-hour period. And this plaque was placed over the entire cornea, the limbus, and approximately 3 millimeters of the surrounding conjunctiva. And what we saw was that the neoplasm completely regressed within 1 month of treatment. The visual acuity in the left eye improved to 20/20, and both the clinical examination as shown by these photos and the anterior segment OCT normalized with a thin corneal epithelium. It is important to note, however, that the patient did develop a visually significant PSC 32 months after the brachytherapy, and consequently he underwent successful phacoemulsification, returning his 20/20 vision in the left eye. After 55 months of follow-up, we've followed this patient and we've seen no tumor occurrence clinically or on anterior segment OCT. And in addition, his vision has remained 20/20 in that left eye. And so finally, for our take-home points. This is the first reported case of plaque radiotherapy used for chemotherapy and immunotherapy-resistant CIN. And although typically not used for intraepithelial disease, it can be considered for localized OSSN in patients who are unresponsive to topical therapies and may be poor surgical candidates. And I'd also like to point out that this case was published in the Cornea Journal if you guys would like a little bit more information. Finally, I would like to thank my mentor, Dr. Carol Karp. None of this would be possible without her help and her guidance throughout the process. Thank you so much for your guys' time, and I look forward to answering any questions you may have.
Hi, my name is Carolina Mercado. I'm a cornea specialist at Bascom Palmer Eye Institute in Naples, Florida, and I'm going to present this case titled Double Trouble, an Ironic Presentation in the Father-in-Law. This is a case of a 70-year-old male patient that comes for evaluation of pterygium in the right eye. He had a history of rosacea, a history of pterygium resection in the left eye with autograft twice in 2017, radial keratotomies in both eyes in 1989, and floppy eyelids. His visual acuity was normal, 20/20 in both eyes, and intraocular pressure was normal in both eyes. And when we look at the right eye, we see this temporal pterygium with a opalescent lesion encroaching to the cornea, but overall it looked like a normal pterygium. Nasally, it looks overall normal, but it has this tiny neovascularization that comes from 1 to 3, but it looks okay. There's no opalescence in the cornea. In the left eye, we see this opalescent lesion that starts at 2:30 until 3:30. We see that it has neovascularization, but it does not reach the margins of the lesion, and a little bit of pigment here in the conjunctiva. So we have this patient that consulted for a pterygium in the right eye that overall looks like a normal pterygium, and the right eye looks okay. But we find this lesion on the left eye that looks a little bit suspicious. So we decide to perform an anterior segment OCT on the left eye, and this is what we see. Here we have a transition from normal to abnormal. We have the thin hyporeflective epithelium, that it's a normal epithelium in the cornea, and then here is the area of the opalescence. Here we see the cut in the unfast OCT. There's a hyperreflectivity transition that is 90 degrees, and we see the thickening of the epithelium in this area. this is suspicious for OSSN. So we reevaluated the risk factors of this patient for any neoplastic lesion. And he didn't have any history of smoking. He had no history of cutaneous melanoma. He obviously had a history of significant sun exposure. He doesn't even have to tell us. He has been growing a bunch of pterygiums in his lifetime. He had no warts in the skin, no venereal warts. He had a history of basal cell carcinoma on the face. And as the most important risk factor for having strange things, he was the father-in-law of one of the cornea fellows at the time. Here I show you another example. First, what we need to do is identify the epithelium. So here we come and follow the line of the epithelium. And we see the difference from the hyporeflective epithelium, that is a normal thin hyporeflective epithelium, to the hyperreflective epithelium. There's an abrupt transition here, and there's a thickening here. Remember that the name itself says it. It's a conjunctival or corneal intraepithelial neoplasia, so it's always going to be confined in the epithelium, and this is thickened. Here we have a big old juicy OSSN. Most patients have two eyes, and we need to remember that this patient consulted initially for a pterygium on the right eye, which means that he also had significant sun exposure on the right eye. Whenever we make a diagnosis of OSSN in one eye, we also take several anterior segment OCT cuts in different clock hours in the contralateral eye. And remember that I show you this image in the nasal part of the right eye that looked normal, only had that tiny vessel, but when we do the OCT in that area, we see this. First we identify the epithelium, and then we notice there's an abrupt transition from normal to abnormal. And when we compare the hypo with the hyperreflective area, the hyperreflective area is thickened. So this is consistent with OSSN in a lesion we can't really see in the slit lamp. The OCT is very useful to identify OSSN. Some studies have shown that there's a 97% sensitivity to identify OSSN when there's a thickness of more than 120 microns in the epithelium. Even though anterior segment OCT can serve as an optical biopsy, we routinely offer the patients the option of getting a biopsy because this continues to be the gold standard, and this patient elected to have a biopsy, and it confirmed in both eyes the diagnosis of OSSN. In the setting of a lesion we can't see. So when selecting the medical management, usually for OSSN, when you have a defined lesion, you can offer the patient surgical or medical management. There have been some papers that have confirmed that there are no differences between efficacy, costs, and quality of life in the management of OSSN. So it's basically a decision by the patient what they prefer. But in special cases like corneal OSSNs, diffuse OSSNs, or extensive OSSNs, it's not ideal to get surgery, and this is our case. We couldn't see in the slit lamp the lesion in the right eye, so we don't have any margins to resect. So we offer the patient medical treatment. At the time we had the three options: 5-fluorouracil, interferon alpha-2 beta, and mitomycin C. I say this that at the time because this case happened in 2020, and since 2021 we've had a shortage of interferon alpha-2 beta. The patient elected to start 5-fluorouracil. It's the cheaper option. The mitomycin we usually leave at the end, as Dr. Karp would say. This is the devil drop. It stings a lot, creates a lot of redness, so that's the last option. So we start with the two options of 5-fluorouracil or interferon alpha-2 beta. Interferon was around $800 per cycle when this patient consulted, so he preferred the 5-fluorouracil. He was started on 5-FU, but he had redness and irritation. This happens in a small amount of patients, but he had side effects and he wasn't responding well to the 5-FU after 2 cycles. So then we decided to to use interferon alpha 2 beta, and he completed 4.5 months. We usually give at least 4 cycles of interferon to resolve any subclinical disease, and he had amazing improvement. Here we see the anterior segment OCT, the patient, and the right and the left eye. This is great for follow-up, and especially necessary in this case because clinically we could never see the OSSN in the right eye. So here we see that the epithelium in the cornea has been normalized. We can see a little bit of hyperreflectivity, but this is with a normal thickness epithelium, and here you can see that there is a angle transition in the reflectivity. There's a normal thickness of the epithelium, and there's also this angle reflectivity. This is more consistent with metaplasia in comparison to dysplasia that we had at the beginning. When there's dysplasia, the cells grow from the basement epithelium up vertical, so it's a 90-degree transition when there's dysplasia, and here we see the metaplasia. So this is consistent with scarring here after the treatment. It's normal. So in conclusion, OSSN can arise from chronic inflammation, sun exposure, among other causes. Some presentations may be subtle. Anterior segment OCT is a helpful tool for identifying subclinical OSSN. Epithelial thickness, hyperreflectivity, and abrupt transition are the characteristic findings for OSSN in anterior segment OCT. Anterior segment OCT can save the day. Thank you very much.
Let me present to you a video report of a clinical case entitled Argentine flag sign as one of the intraoperative complications of deep anterior lamellar keratoplasty. Patient P, born in 1978, came to our clinic with a diagnosis of keratoconus in both eyes, which he had been suffering from since 2013. He was offered a deep anterior lamellar keratoplasty, DLK. The indications for surgery on the right eye were corneal pachymetry of 319 microns in the center and a corneal dispersion index of 98 diopters. DLK surgery was performed according to the standard technique. First, intraoperative 8-point contact pachymetry is performed, which we compare with pentacam parameters. After that we make a trepanation cut on 3/4 of the cornea with a trepan. Then we mark the cornea for subsequent suturing of the donor graft. Several air bubbles are injected into the front chamber for marking. After that we isolate the trepanelated part of the stroma with the dissector, also make a small port for the subsequent insertion of a cannula, which is the second step in DLK, the injection of the air big bubble. At the moment the air bubble was injected, we felt a click inside, and after complete evacuation of the stromal tissue, we saw a decimet membrane rupture similar to the Argentine flag, and we called this the Argentine flag sign on DLK. Of course, in this situation, the question arose, either to switch to a penetrating keratoplasty or to complete DLK. Knowing the advantages of DLK over PKP, we still decided to complete a deep anterior lamellar keratoplasty. After complete removal of the stromal tissue and staining of the decimet membrane, we see an Argentine flag type tear. After some manipulations, we see that it is still possible to achieve complete closure of the decimet membrane, which in the long run will not give us much disruption of the functionality of the endothelium itself. We perform all manipulations under the control of intraoperative OCT. Subsequently, we prepare a donor cornea to complete DLK. Suturing is performed according to the traditional technique, first with 4 fixation sutures and after that with 2 winding sutures. Sutures are placed to a depth of 2/3 of the corneal stroma. Then we inject air into the anterior chamber and we see a wide gap in the decimet membrane, which when manipulating the cannula from the outside does not allow to bring the edges as close together as possible. After that, we tried to inject viscoelastic into the anterior chamber and bring the edges as close as possible and bring the decimet membrane with endothelium closer to the stroma. By manipulating the cannula we managed to bring the edges of the decimet membrane rupture as close as possible, which subsequently allowed us to achieve a high functional result. On the OCT, we can see the adjoining membrane to the stroma. Then we inject C3F8 gas into 3/4 of the anterior chamber. This concludes the operation. On the 4th day after the operation, the patient's visual acuity was 10%. On the 11th day after surgery, according to OCT, the width of the gap in the decimet membrane was 85 microns. On day 13 after surgery, the gap width in the decimet membrane had narrowed to 50 microns and visual acuity had increased to 40%. On the 14th day, the patient was released for further observation at the place of residence. Thank you for your attention.
Thank you, the authors, for all interesting case presentation, and I would like to open the discussion. So maybe if I could ask the question regarding the first case, what about the maximal IOP in this patient? Have you seen in this patient the high values of the IOP higher than 18 millimeters of mercury?
Hello, doctor. So for this patient, the highest IOP that we measured is just around 20. So I think that's for this patient, that's underestimated since the patient has decreased CCT.
Generally, we see that the patient has very quite advanced glaucomatosis neuropathy and almost closed angle in both eyes. So it is rather improbable that the IOP is so low. Maybe this is the underestimation, or very low, or just normal tension glaucoma in this case, but rather this is impossible. And the other question is, what are your surgical options for this patient, if needed?
If needed, we can do trabeculectomy, and if not trabeculectomy, we can perform glaucoma drainage device.
We have also some cases with ICE, but all with the poor prognosis, and this is why I asked. Despite of doing many surgeries, the IOP and the eye has had this all eye with this ICE had a very poor prognosis. So if bilateral, it is quite not very good case for the patient. Thank you.
Thank you, doctor.
I also had a comment or question on the ICE case. It was very interesting, very well presented. Yes, indeed, the pressures are really low compared to the amount of glaucomatous damage. And I wonder if there's not something else in addition to ICE. The fact that it's bilateral, I assume you did a full investigation, but we should always keep in mind trabecular dysgenesia that can cause some patterns with PAS, as you showed. What was very interesting that the patient may not have read the book, so it does not fit the standard that we see. I was actually going to ask about surgery as well. You have a preference more towards trabeculectomy or two, because we know that the risk of closure of the scleral flap or the ostium from the membrane, you had more towards the tube than the trab in these cases?
So for this patient, if needed to perform surgical procedure, so what we plan ideally is to have GTT. Unfortunately, here locally in our institution or here in our part of the Philippines, it is very difficult to get GTT. And for problem is a financial constraint. So our another option is to have or to perform trabeculectomy.
So if I may comment, in my opinion, we do, in these cases, we do all the possible procedure that can be done, because generally we have the poor prognosis. So we try to start from the trabeculectomy, knowing that this patient have also the problem with the corneal endothelium. So if we plan to put the tube in the anterior chamber, there will be always the problem, further problem with the endothelium. In this patient, you see that there is also an own lens, so maybe the cataract surgery and afterwards, if needed, the tube implantation. I even tried to do the gut surgery in one case of ICE, thinking that this also may be the option. It was after the failed trabeculectomy and 2 revisions, so just before the tube implantation, and the angle was not very destroyed as in your case.
Anyone has any comments on the CIN case? Oh, sorry, I interrupted you. Were you going to say something?
No, I have a comment on another case, on the last case about the Argentinian flag. Maybe later you tell me.
Go ahead. We can go ahead.
Yeah. So during the presentation, I called it was very interesting case. You've seen this as well. by Valery Serdyuk, and I sent him an SMS and greeted him with this perfect case, and we did some small short discussion right now on the phone with the author. Unfortunately, he cannot be present. So he just as comment about it, he was wondering that in spite of the rupture of the cement membrane, actually penetrating trauma of the cornea, still he had during the surgery, he had an anterior chamber. He could maintain the anterior chamber, and we discussed that probably this is the superficial tension of the air bubble, which could stick to the inner surface of the endothelial cells, endothelial layer, and maintain the integrity of the anterior chamber. It was very interesting and very unique case. Thank you.
Anna Machalinska speaking. I would like to comment on the last case on DALK. I really congratulate the author of really spectacular surgery. I'm really impressed. And DALK surgery is it's a part of my interest because I perform a lot of DALKs in my surgery room, and I have two questions. We know that the eyes, the keratoconus eyes, after eye drops, they are at risk of descemet rupture. So my question is, was it the eye that underwent eye drops? Yes, this is the first question. The second question is concerning about the technique. Yes, you perform the big bubble technique. So using this technique, we obtain two types of bubble. The type 1 bubble, which means that you get into the predescemet layer. Yes, so you separate the stroma from predescemet layer. Predescemet layer was first described by Dua, yes, and the type 2 bubble, which means that you separate the bare descemet membrane. So I guess that you gained the type 2 bubble, yes? Am I correct? So I would be grateful if you could answer my concerns and my questions.
I don't know whom you have asked, because I'm not the author. I just spoke to the author on the phone, so we can discuss this question, your question. So because
yes, I'm asking
the group,
the presenter.
The presenter is not here, I think.
It's not here. Okay.
But you can discuss what you think about this. I think yes, in Germany this is it became very rare surgery, but there's
I'm
still
from Poland, and in
yes,
Poland,
I know.
yes, like in Germany, it's not common surgery, but because I think of many reasons. Yes, it's time-consuming surgery, and it's not so easy. It's also it's very difficult to predict the effect. Yes, as I've said, we use different techniques like big bubble technique, manual dissection, visco dissection. So there is no one common technique. Yes? So every surgeon use his or her own technique. And I think that's why the results are not comparable. It's difficult to compare them between surgeons. Yes. I think in Italy, it's quite common in Italy. And for example, Professor Busin is the leader in DALK technique.
I had a question about the CIN case, very successful. Any insight whether you could try the same technique across the board, not just for some specific cases?
So good morning, good afternoon, and greetings from Bascom Palmer Eye Institute. I'm Carol Karp, and wanted to congratulate Michael Antonetti and Dr. Mercado for the cases and for having this forum. Thank you so much for including them. So a few things. On the second case, which Dr. Mercado presented, I just wanted to highlight that high-resolution OCT was so critical in detecting the possibility of dysplasia, which was confirmed by biopsy. And then in Michael's case as well, that patient that first came from Mexico had an equivocal biopsy there, which sometimes is just hard for pathologists to read small samples. But the high-resolution OCT confirmed that there was persistent disease, which we confirmed with biopsy. And to answer your question, for the case that Michael presented where we used a plaque, and that was the first case that we know of that was published for intraepithelial disease, the key thing in using the plaque is that the plaque can cover the area of disease. And so this patient had corneal intraepithelial neoplasia, but 9 other biopsies all around were negative. So it was really isolated to the cornea, and it made it a perfect candidate to put on the COMS plaque 18 millimeters right over, because you certainly wouldn't want to plaque the patient and find out that in another area there's weeds growing of neoplasia. So in very stubborn cases, or in cases where I can't cure them with medications or with excisional surgery, this is something now that I have in my toolbox that worked very nicely and was very easy. So I would say, yes, I think that we should include this in our toolbox, but it has to be in patients who've had map biopsies and the disease is localized to where you can treat it with a plaque.
So going back to now the OSSN versus the region, I agree the high resolution OCT here, ASOCT, was crucial. How different are those findings from, let's say, just the region? I see how the transition zone was crucial, so it's easy to differentiate from normal, but how to differentiate from something that's not as great like that?
Yeah, so as the panel knows, the OSSN can hide in pterygia, and depending on what you read, anywhere from 1% to almost up to 10%. And clinically, sometimes it's easy and sometimes it's subtle. Now, with the OCT, you do see changes of pterygia with OCT, and the things I'd point out is that pterygium is a subepithelial disease, but the epithelium is hyperreflective just due to sun damage. But it's not cancer, and it's thin. So with OSSN, it's thickened hyperreflective epithelium. So when you see something that Dr. Mercado mentioned in our studies and supported by many others, when you see thickness of over 120 and the OCT can measure it, you should really worry that this is a neoplastic process. So it's okay, it's normal to have some hyperreflectivity over pterygium, but not that thickening. And then your question was about the transition is very true, that when there's an abrupt transition, it's highly suspicious for OSSN. And as Dr. Mercado pointed out, when it's angled, that is more like metaplasia or not neoplastic. So in summary, thickness over 120 of the epithelium and an abrupt transition should make you highly suspicious and decide whether you want to biopsy or whether you can see it and you want to treat.
Thank you.
Thank you.
How are we doing with time for discussion? Are we good? I'm sorry? Okay. So I'd like to thank everyone. Awesome presentations and discussion, and I hope we can participate in more of those in the future.
Thank you.
Thank you all.
Hi, how are you? My name is Jaime Martinez. I'm assistant professor at Bascom Palmer Institute. Thank you very much for the invitation to give this talk. I'm going to start with my clinical case. I do not have any financial disclosures in regards to this talk. So this is about a 35-year-old male patient who was referred to us because of a corneal infection on the left eye for 5 months of corneal infection. Patient complains of pain, and also patient complains of using a lot of artificial tears for more than 5 months, with no relief of symptoms in both eyes. He was using every single eye drop over the counter. Past medical history, as I mentioned, corneal infection. It was pseudomonas at some point, corneal glue twice, and as well recurrent oral herpes infections. And I'm not going to disclose everything to make it more interesting. Eye exam was visual acuity was 2400, left eye was hand motion. And you can see the clinical photos on the right eye. You can see completely keratinized surface. Pretty not a good eye was not. It would seem really dry but quiet. But the left eye had a severe corneal infection. You can see treated with a fortified 2 times of glue with no resolution of infection. So what do you do? So you have to think maybe something's going on, maybe fungal, maybe other things that are not co-infection, right? Maybe recultured, maybe do PCR, and maybe do reglue or corneal transplant, or as well at the same time corneal patch or conjunctival flap. That's a question, right? But we have to stop and think. So what's going on? Why this severe dry eye, non-responding corneal infection? So we have to go and see the right eye. So the right eye, you can see pretty rough surface. You have a close-up picture, really nice keratinized surface. So we need more questions that I'm going to save to make it more, that I'm not going to mention to make it more interesting. We have to do additional testing, right? So we have to know if there's any vitritis, any retinal detachment, etc. So B scan was normal. There was no vitritis on the left eye. The cultures that I mentioned, it was recultured, negative for fungal or acanthamoeba. It continues to be positive for Pseudomonas corneal infection, but good news, it was not resistant as we thought, susceptible to antibiotics. So what did we do? So we decided to do a corneal transplant. You can see we're removing as much infection as possible. We're doing a corneal transplant. So here we're trephinate the cornea. We can see the iris is just plastered into the cornea, little vessels, a lot of corneal neovascularization. We're putting the corneal graft with no issues, a lot of hyphema. We try to remove the hyphema as much as possible to prevent any increase of pressure post-op. And also we put an amniotic membrane to help healing, and injections, subconjunctival injections. And also we did tarsorrhaphy because patient, we know we have a difficult healing, and continue with 45 tobramycin and moxifloxacin. Unfortunately, patient came back, patient continued with pain, so I opened the tarsorrhaphy. It was not full tarsorrhaphy, it was like 50%. It was not a full tarsorrhaphy, so you can see through the middle half, so patient could be able to put drops, and I can do an eye exam fully. But unfortunately, it came back about 2 weeks after surgery, so the patient lives far away, so we kept, it was difficult follow-up, and patient came back with a recurrent infection, unfortunately. So what to do now, right? Really bad infection over minute cornea. So we decided to do a research project that we have, the Rose Bengal photodynamic antimicrobial therapy, which is a light treatment with green light and Rose Bengal to kill resistant corneal infections. We have about 70% success rate in general. We've been published that in previous papers. So we did that, and at the same time we did a conjunctival flap. You can see here we did a flap to bring those blood vessels and help healing, and also we did cryotherapy over the cornea. Here we're doing a little of the removing the conjunctiva, bringing those vessels, putting amniotic membrane. Week 1, the conjunctiva retracted, the infection was not doing better, developed a sematocele, and patient ended up having the sematocele. So we need to do something about it. Patient was in pain. So we decided to do a big corneal graft, which we wanted to prevent it, but it didn't work with the periotomy. And then we did a periotomy, and then we did a full cornea transplant. Again, we did remove the cataract due to the angle closure, and we closed the conjunctiva. So this is like about week 1 to week 3. Corneal is doing better, no infection, ulcer healing. So we need to pause here and go to the good eye. So why is this happening? Why this patient is done healing? Recurrent corneal infection, the right eye, keratinized corneal, and ocular surface. Some of the questions that they were not mentioned or answered during the medical history was, one of them, any past medical surgical history, and patient had a gastric bypass. Actually, it was 8 years prior to presentation, so that was quite interesting. How far before the symptoms started? So 8 years. And the other one was any other symptoms besides the pain and dry eye, and it was nyctalopia. So patient developed nyctalopia for quite a while. And also one other thing is it was a patient taking multivitamins. A patient was a little bit uncompliant on vitamins taking oral. So what's our diagnosis? Our diagnosis is a corneal ulcer caused by vitamin A deficiency from a gastric bypass. So of course we did a lab workup such as autoimmune diseases and infectious causes such as TB, syphilis was negative, and vitamin A was pretty low. So back to the patient that unfortunately was a huge back order, the whole country of vitamin A intramuscular. We're not able to get any vitamin A. Unfortunately, there was no date for us to get the vitamin A intramuscular, so we had to start right away oral and suspension, high doses. So back to the patient, we started this vitamin A oral and suspension by mouth. A patient did really well on the right eye. Patient started getting better vision, went back to 2025, 2020 vision, and there was no more kerathinized ocular surface. So this is after 2 months. This is before, and this is after quite drastically changes. So take-home points is it's important past medical history, past surgical medical history to be able to get diagnosis and treat this patient as soon as possible to prevent blindness and prevent what happened to this patient, which definitely patient had a bad outcome due to the corneal ulcer. This is my reference. Thank you very much.
Hello, my name is Reta Serikaitė. I'm from Lithuania, Kaunas City, the Hospital of Lithuanian University of Health Sciences, Ophthalmology Department. Today I will be presenting a case report on the impact of child's dietary habits on ocular surface changes. In June 2024, a 9-year-old patient was presented to our department. During medical analysis, we learned that the patient is diagnosed with autism and that he is a picky eater. His diet was limited to French fries, cured sausages, still water, and Coke. The patient was complaining about episodic vomiting and diarrhea, which have been recurring every 5 to 7 days since December 2023. In addition to that, papular rashes on the skin were observed. At that time, the boy was already followed by a pediatrician, gastroenterologist, and infectologist. Due to high immunoglobulins E, the patient was referred to a genetic counseling. Upon his arrival, the boy also complained about a red left eye. The patient was diagnosed with conjunctivitis and tompromycin drops were prescribed for the treatment. Since no improvement was seen after 2 weeks, the boy was hospitalized for a detailed examination. Due to his general condition, the boy's examination was rather difficult and challenging. The corneal sensitivity test was also complicated. During slit lamp examination, conjunctival injection, punctate epithelial keratitis with corneal epithelium irregularity and swollen epithelial cells was observed in the left eye. The patient was treated with levofloxacin and cyclopetrala drops as well as tobramycin ointment for the night. With no improvement, drug toxicity was suspected and before mentioned treatment was completely stopped. Instead, a treatment with artificial tears and mom's blood serum drops was started. I would like to mention that all pictures except anterior OCT are taken from publications as we were unable to take our own. So after 1 week, semicircular epithelial opacity in the lower part of the cornea, punctate epithelial erosions were observed, while his anterior segment OCT showed no pathology. The patient was discharged to continue previously mentioned treatment at home. 1 month later, the results from the laboratory came back. The boy was tested for positive herpes simplex immunoglobulins M and was prescribed with acyclovir tablets 400 mg by scheme. After 1 month, still no improvement was observed, and in addition to the left eye, both eyes were involved now. During slit lamp examination, wrinkle, dry conjunctiva, and xerosis on the lower part of the cornea was seen. To recap, let's see what we learned so far. The patient has episodes of vomiting and diarrhea. He is a picky eater, and we saw no improvement within the treatment. During the last examination on the slit lamp, dull and wrinkled conjunctiva with corneal xerosis on the lower part was observed. Taking all to consideration, vitamin A deficiency was suspected. Laboratory results confirmed the suspected diagnosis, and based on the literature, immediate treatment was started. 200,000 international units orally in 3 doses for a total 600,000 units is recommended for treating xerophthalmia. The first dose is given immediately upon the diagnosis, the second on the following day, and the third dose at least 2 weeks later. It is important to note that besides eye issues, vitamin A deficiency also causes non-specific dermatological problems such as hyperkeratosis and trichodermia, also known as follicular hyperkeratosis or frog skin. The treatment of vitamin A deficiency proved to be successful, and the boy's ocular surface as well as skin condition can finally improve. Let's take a deeper look. What is xerophthalmia? Xerophthalmia is ocular disease resulting from a severe deficiency of vitamin A. Although vitamin A deficiency is rarely seen in resource-rich countries, xerophthalmia also has been reported in individuals with extremely limited diets due to mental health disorders. Vitamin A deficiency can lead to metaplasia and keratinization of mucus-secreting epithelium, resulting in conditions like conjunctival and corneal xerosis, corneal ulcers, keratomalacia, and scarring. Vitamin A deficiency also impairs rod function, leading to night blindness. In order to diagnose xerophthalmia, we should make sure to know patient's medical history, perform complete ophthalmic examination, and check serum vitamin A. Additional tests such as impression cytology, dark adaptation, and electroretinogram could be also done. To see how xerophthalmia is graded by WHO, please refer to a table above. It is very important to realize that children do not first develop night blindness, then bited spots, and then corneal ulcers. If we talk about night blindness, children usually do not complain, but they become less active in the dark room. Conjunctival xerosis, difficult to detect and not very reliable sign. Bited spots seen below are pathognomic sign, triangular patches of foamy keratinized epithelium in the interpalpebral zone. Corneal xerosis is a sign of sudden acute deficiency. The cornea becomes dry because glands in the conjunctiva no longer function normally. It also increases risk of infection. Corneal ulcer is seen if acute deficiency is not reversed as a matter of urgency. The cornea can become ulcerated and melt away. Keratomalacia, seen below, most severe form of xerophthalmia. Cornea can be destroyed just in a few days. The end of result of corneal ulceration and keratomalacia is corneal scarring. Xerophthalmic fundus, yellowish peripheral dots may occur in advanced cases and is associated with decreased electroretinogram amplitude. When it comes to the treatment, it is important to note that the prompt administration of high-dose vitamin A, early ophthalmological signs such as impaired rod function, conjunctival xerosis, and night blindness can completely resolve within approximately 2 months of supplementation, with no long-term consequences. For the treatment of xerophthalmia, vitamin A is given in 3 doses at the age-specific doses listed above. The dose for adolescents and adults is 200,000 international units orally in 3 doses for a total 600,000 units. The first dose is given immediately upon the diagnosis, the second on the following day, and the third dose at least 2 weeks later. In addition to the medical treatment, the patient's diet should be supplemented with foods containing vitamin A and zinc, as zinc is required to help transport vitamin A through the body. Also, intensive ocular lubrication with preservative-free artificial tears every hour and artificial tear ointment before the night is recommended. So, our take-home message: vitamin A deficiency should be considered in individuals with extremely limited diets, even in developed countries. Key diagnostic feature: bited spots, triangular patches of foamy keratinized epithelium in the interpalpebral zone. Immediate treatment upon the diagnosis is crucial, as early ophthalmological symptoms such as impaired rod function, conjunctival xerosis, and night blindness can typically resolve within approximately 2 months of supplementation. And here is my list of literature, and thank you for your attention.
Hello everyone, I'm Dr. Ophthalmologist Paulina Mikulėnaitė from Lithuania, and today I am going to talk about congenital corneal abnormalities associated with multiple disorders. So let's begin with short patient's medical history. Right now the patient is 6-year-old girl. She was born at 40 weeks gestation. The pregnancy was uncomplicated. Mother only had herpes during pregnancy. After birth, the positive pressure ventilation was provided. Hypotonia, hypertension of the dorsal extensors, leaned back head, lethargy, and bilateral deafness were observed. A gastrostomy tube was formed due to dysphagia, and later cochlear implant surgery was performed. Nevertheless, the patient is deaf. She is not able to walk and talk, and contact is maintained through gestures, and vision. There are no known hereditary diseases in the family. Her parents are healthy. When she was 2 years old, she had right eye corneal erosion unresponsive to treatment. Antibiotic drops, artificial tears, and ointments, regenerating agent were used. Despite intensive topical treatment, only a slight improvement was observed. Later, severe inflammation associated with hypopyon and iris hyperemia developed in the right eye. No pathogen was found. Since the corneal defect was unresponsive to conservative treatment, amniotic membrane transplantation was performed, and the corneal ulcer epithelialized, but a vascularized central corneal opacity formed, as you can see in the pictures. A year later, patient scratched her left eye with the nail and had corneal erosion again, but only in the different eye. And that erosion wasn't responsive to treatment and progressed to the stromal corneal ulcer with surrounding congenital edema and iris hyperemia, as you can see in the pictures. Further examination was made. So the patient carries a normal female karyotype. The patient has dysplastic facial features. Also, her MRI showed hypoplastic trigeminal nerve. Corneal sensitivity and sensation in the distribution of trigeminal nerve were not assessed due to cognitive function impairment and general patient's condition. A very rare blinking rate once per minute was observed, and also no secondary causes of corneal anesthesia were found. Due to prominating and actively vascularized corneal opacity in the right eye, the treatment with recombinant human nerve growth factor was provided. Corneal epithelium defect healed, but severe corneal opacity with neovascularization formed. Therefore, to inhibit further corneal neovascularization, we treated patient with anti-VEGF with 3 subconjunctival injections, and positive effect was observed because that neovascularization became less active, as you can see in the photos. Since now patient uses artificial tears during the day and ointment at night, and is still under supervision by an ophthalmologist, usually twice a year, and now her eyes are in stable condition. So what was the diagnosis of this patient? So the patient was diagnosed with bilateral congenital corneal anesthesia, secondary to bilateral trigeminal hypoplasia, and bilateral neurotrophic keratopathy. Congenital corneal anesthesia usually presents in early childhood between the age of 8 and 12 months. It is usually sporadic bilateral disorder. There are more cases of congenital corneal anesthesia reported in the literature that are associated with other disorders, but none of them is similar to ours. There is a possibility that the patient has multiple diseases, since only a part of patient's clinical signs may be due to glycoprotein metabolism disorders. We are not aware of any condition in which brainstem dysfunction, such as deafness and dysphagia, congenital trigeminal anesthesia, and glycoprotein metabolism disorder are presented together. And it is essential to exclude acquired causes of corneal anesthesia before the diagnosis of congenital corneal anesthesia. So, in summary, neurotrophic keratitis due to congenital corneal anesthesia can be a cause of severe vision impairment in childhood. Various treatment approaches should be considered in order to achieve the best possible results. Similar treatment results were obtained in both eyes with two different treatment methods: amniotic membrane transplantation and recombinant human nerve growth factor. A combination of various factors, such as the stage of neurotrophic keratitis at the beginning of the treatment, the underlying cause, patient's general condition, and availability of medication contributes to the final treatment outcome. So thank you for your attention, and I'll be waiting for the questions in the question session. Thank you. Bye.
Hello, dear colleagues. Thank you for the invitation in this conference. I would like to begin by presenting a clinical case, ocular manifestation of skin diseases. An 18-year-old man arrived complaining of itching, sensitivity, photophobia in both eyes, and worsened vision in the left eye. Ophthalmological history: eye redness, lesions recurred repeatedly about 5 years, positive effect with treatment lasting up to 1 month, no comorbidities or allergies. In examination, both eyelid margins are hyperemic and thickened, with telangiectasia present, and there is a plaque on the eyelashes. The conjunctival injection. Also, we can see neovascularizations in the lower part of the corneas, subepithelial opacities, isolated subepithelial infiltrates, and ulceration, especially in the left eye in mid-periphery of the cornea. The endothelium is clear, the irises are calm, and there are no significant inflammatory reaction in the deeper structures. No changes observed in the laboratory blood test and other investigations. So what etiology could we consider? What other examination would you do? We did a microscopic examination of eyelashes and determined the Demodex folliculorum. So what diagnosis it could be? Demodex blepharitis suspected. We have a new symptom. The patient complains of a mildly itchy rash on the facial skin about 2 months. So what we have? Eyelid telangiectasia, hyperemia, plaque on the eyelashes, corneal neovascularization, opacity, subepithelial infiltrates and ulceration. We found Demodex folliculorum. We have rash on skin and no improvement with treatments in childhood. So what diagnosis? Rosacea facie papulopustulosa. For the treatment, we prescribed topical drops and ointment and systematically prescribed doxycycline 100 mg per day. Dermatologist added metronidazole ointment and recommended to avoid irritating factors such as abrasive facial skin care products, spicy foods, sauna, sun exposure. Here you can see the right eye before and after treatment. Apart from the treatment, the condition began to improve. The corneal lesions have epithelialized, leaving some small opacities. Here you can see the left eye before and after treatment. So rosacea is a chronic facial skin condition characterized by marked involvement of the central face with transient or persistent erythema, inflammatory papules or pustulas, telangiectasia or hyperplasia of the connective tissue. Most often affected zones are the forehead, nose, chin, and cheeks. Some symptoms may flare for weeks to months and then go away for a while. According to the patterns of signs and symptoms, 4 major subjects of rosacea are described. One of them is ocular rosacea. The ocular signs are non-specific and often overlap. The eyelid margin is hyperemic, thickened with telangiectasia, obstructed meibomian glands, and crusting on the eyelashes, along with the presence of demodex mites and stairs. When the conjunctiva is affected, there is a chronic inflammation with the formation of conjunctival nodules or granulomas. Moderate to severe cases involve corneal damage, typically affecting the lower part of the cornea, but the damage can progress toward the center, ranging from the small punctate keratitis to corneal vascularization, scarring, or even perforation. 55% of children with eye injuries present without signs on the skin. Skin damage, if present, is significantly milder than in adults. If there are no skin signs, the disease is diagnosed based on eye symptoms and family history. Ophthalmologists often diagnose ocular rosacea in children first, but the diagnosis is delayed by an average of 2 years. In childhood, the condition is often bilateral and presents with recurrent stays, telangiectasia of the eyelid margins, meibomian gland dysfunction, chronic blepharoconjunctivitis, and corneal damage. The lower quadrant is most commonly affected, but the lesion can expand circumferently and involve the center. In children, rosacea, the most common cause of non-infectious keratitis. Due to delayed diagnosis, corneal vascularization and scarring are more commonly observed in children. There is a strong relationship between rosacea and meibomian gland dysfunction, which has been reported in 80% of patients with ocular rosacea. Ledivien controls bacterial and demodex mite overgrowth, and worm compresses melt the meibum to allow increased turnover. Dietary supplements such as omega-3 fatty acids have also been shown to improve ocular rosacea symptoms. Cyclosporin works by inhibiting T lymphocytes and cytokines with the conjunctiva, thus reducing apoptosis and increasing tear production. Topical cyclosporin is an acceptable long-term treatment for management of ocular rosacea due to its favorable safety profile. Topical metronidazole works as an immunosuppressant, antimicrobial, and anti-inflammatory agent. Tetracyclines have been the mainstay of treatment of ocular symptoms due to their antimicrobial and anti-inflammatory properties. Doxycycline has fewer side effects than other tetracyclines, as a smaller dose is required for a therapeutic effect. Less severe disease 50 mg or 40 mg per day for long-term maintenance. Tetracyclines are contraindicated in children under 8 years old. Erythromycin is an effective alternative to doxycycline, particularly in the pediatric population under 8 years of age. In an oral or topical form, is reported to be an effective alternative to tetracycline due to its shorter treatment time, lower dose, reduced side effects, and limited drug interaction. Azithromycin has also been shown to promote differentiation of meibomian gland epithelial cells. Antiparasitic drug ivermectin is suggested to manage ocular rosacea by targeting demodex mites and sought its anti-inflammatory properties. High-intensity non-coherent light is now used following meibomian expression in patients with ocular rosacea. So here you can see the table with topical treatment of ocular rosacea with doses and treatment duration. And in this slide you can see the table with systemic treatment of ocular rosacea with doses and treatment duration. And in very severe cases, we use surgical treatment like only amniotic transplantation or keratoplasty. So take-home messages. Ocular rosacea is an important and undiagnosed chronic inflammatory disorder observed in children. The delay in diagnosis is greater than 1 year in the large majority of cases and may lead to serious ocular sequelae. Treatment requires a minimum of 3 months antibiotic therapy and a subsequent gradual tapering. Thank you for your attention.
Good afternoon, ladies and gentlemen. In this Enigma session, I would like to present bilateral choroidal effusion following treatment of pseudophakic cystoid macular edema. Our patient, it was 87-year-old white man who underwent 2 months before uneventful cataract surgery, but to our center he was admitted because of vision deterioration, and in OCT we could see pseudophakic cystoid macular edema of his left eye. His best corrected visual acuity in the right eye was quite okay, 0.7, but in the left it dropped to 0.2. So, as an Irving-Gass syndrome, we introduced standard treatment 4 times a day, non-steroidal anti-inflammatory drugs, and acetazolamide twice daily with potassium supplementation. To our surprise, 7 days later, the same patient was admitted again with acute painless bilateral vision deterioration. His right eye vision was 0.3 and left vision was 0.4. Anterior segment slightly shallow, but in the posterior segment we saw inferotemporal and inferonasal choroidal effusion, as it is depicted in the slide, in the pictures here. In the ultrasound, we could see typical signs of choroidal detachment in both eyes. But to our surprise, no cystoid macular edema in the left eye, but only residual macular SRF was observed in both eyes. Fluid appeared close to the optic disc, and we could notice macular choroidal folds. The pressure was normal. So the question was, what happened here? What was the cause? What to do next? We reviewed the treatment. It was standard treatment as it depicted here. So we started to dig out what might be the cause. How it could happen, the choroidal detachment in such situation. And reviewing the literature, it turned out that the cause was carbon anhydrase inhibitor acetazolamide, because it was described that after oral and topical use of these medications, choroidal detachment may develop because of ciliary body edema and anterior rotation, which results in anterior displacement of lens iris diaphragm and choroidal detachment. But again, the question remained the mechanism, and it is described that carbon anhydrase inhibitors can give us idiosyncratic reaction to the medication itself, or a sudden significant drop of intraocular pressure can be the cause of choroidal detachment. So there are these 2 mechanisms. The most frequently reported cases of choroidal detachments after taking these medications are patients treated for acute primary angle closure glaucoma. These are also several cases reports showing choroidal detachment in patients taking acetazolamide prophylactically after cataract surgery, and it was described in people taking carbon anhydrase inhibitors in order to avoid altitude sickness. Knowing that the cause was the acetazolamide, the drug was immediately discontinued. We also introduced dexamethasone eye drops 4 times a day to both eyes, mainly to reduce ciliary body edema and also to create the pressure rise. Bromofenac eye drops was continued, and also atropine in order to help ciliary body rotation, posterior rotation. And it resulted in right and left visual acuity improvement. Anterior chamber deepened and choroidal effusion resolved, as it is depicted in these two pictures. Residual macular fluid persists in both eyes, but fluid next to the optic disc resolved and choroidal folds disappeared. So final results, we could achieve visual acuity improvement to 0.7, 0.6, and after 2 weeks, all medications were discontinued. To conclude, to the best of our knowledge, this is the first description of bilateral choroidal effusion following treatment of Irving-Gass syndrome with oral acetazolamide, and the discontinuation of carbon anhydrase inhibitors with topical steroids and mydriatics introduction leads to complete resolution of this condition. Thank you for your kind attention.
Hello, my name is Krishna Kishore from Bascom Palmer Eye Institute. I'd like to thank Dr. Grabowski for the kind invitation to present the case study that I have. My case study is titled 2020 M Blurry. I have no financial disclosures. This is a retired CEO referred for evaluation for cataract surgery, history of LASIK in 1999. My left eye cannot see well. I see a line was essentially the chief complaint. The exam was 2020 without correction. Intraocular pressure was 14 to 18. In the right eye, left eye was 17 to 21. Bit asymmetric. Corneal thickness after LASIK was 507, 513 in the right eye and left eye, respectively, after LASIK. Gonioscopic examination showed grade 4, no peripheral anterior synechia, 1+ pigment in both eyes. He did have a family history of glaucoma with the father. Dilated fundoscopic examination shows cupped disc of 0.5 in the right eye, 0.65 with inferior thinning in the left eye. There's a posterior vitreous detachment in the right eye. The macula in the right eye shows the epiretinal membrane. Left eye was essentially normal. Blood vessels in periphery were normal in both eyes. So we had to try to figure out what the reason for the symptoms were. So due to the asymmetry of the intraocular pressures and the cup to disc ratios, we decided, hey, maybe let's go down a path for glaucoma. But the visual fields were essentially normal. The patient still was complaining of left eye being not right, seeing that streak of a line in that left eye. So OCT macula shows in the right eye, no intraretinal subretinal fluid in both eyes, but an epiretinal membrane in the right eye. OCT of the nerve fiber layer is essentially normal in the right eye with some infratemporal thinning in the left eye with some artifact. The next step was, looks like the patient from a glaucoma standpoint might be fine because there's no true visual field defects, but he does have changes on the nerve fiber layer. Now, should we get a full workup, which includes a neuro-ophthalmic evaluation or a retinal? So we decided to go ahead and be complete, and we referred the patient for a potential, is there a vascular reason for that decreased vision or that streak in that left eye show? But the retinal consultation came back with epiretinal membrane and cataracts, which were non-visually significant in both eyes. And the neuro-ophthalmic examination showed there was, with the imaging, no masses except some inferior thinning of the optic nerve head of the left eye. And the labs were essentially normal also. And the ganglion cell analysis shows there's some borderline thinning in the macula in that right eye and some inferior changes in the left eye. And this is the funnest picture of the optic nerve head. And the right eye shows some peripapillary atrophy. Left eye does show some infratemporal thinning with some peripapillary atrophy. And if we step back and we kind of take a peek here, so it looks like the OCT in the right eye is normal. Left eye shows some inferior thinning. Doesn't really correlate with the visual field in that left eye, though. And the gangliosynal analysis shows some inferior thinning. So does the OCT, but really doesn't correlate on visual fields. Now, what's the next step here? From a retinal standpoint, everything was normal for them. From a neuro-ophthalmic standpoint, everything was normal. The next step is we got to try to figure out, hey, what else can be done here? Then we thought, hey, potentially performing a 10-2 visual field could give us that next insight here. So that's exactly what we did, where we got a 10-2 for that left eye and shows, voila, probably that paracentral scotoma that he was kind of complaining about. And if you look at the 24-2, it tests points 6 degrees apart, whereas a 10-2 tests points every 2 degrees. And the 24-2 is designed to detect arcuate defects. Here is a drawing that shows that the 10-2 looks at that central portion of the visual field, and the 24-2 is designed more for those arcuate defects and tests points a little further apart than the 10-2. So if you also follow the isn't rule, it shows that the thickest of the optic nerve is thickest inferiorly and thinnest temporally, and our patient here had those changes infratemporally, kind of pointing toward that glaucoma diagnosis potentially. And the infratemporal quadrant of the circumpapillary nerve fiber layer is susceptible to damage and can correlate to damage of the visual field, which our patient did have. So again, if we step back, now the picture makes a little bit more sense here. There's changes in the nerve fiber layer of the OCT, along with that visual field of the 10-2, correlating to the OCT, the gangliosynal layer, and the optic nerve head. So in this situation, we need to, one, use all the data that we have, use all other ancillary tests that we have, specifically in this situation where we had to use the 10-2 visual field to point us toward that diagnosis. And also, always, we're all very busy, but at times we just need to step back and, hey, listen to the patient and try to figure out what the diagnosis is. Generally, they'll point us in that direction. This patient was complaining of something centrally or paracentrally, which we looked at the macula, the visual field, specifically the 10-2 visual field. And finally, this gives us a diagnosis of primary open-angle glaucoma. And also, if you look at the pressures, they were a little asymmetric. The left eye being a high normal, and patient did have LASIK done. So that 21 pressure, that high normal, the fluctuations could probably been a little bit higher, maybe 23, 24. So we started treating them, and him and the patient has been stable ever since. Again, I'd like to thank you for the opportunity to speak, and hopefully this was an interesting patient, and you can use that 10-2 appropriately to try to figure out patients who have those paracentral changes. Again, thank you so much.
Okay, thank you everyone for the very insightful presentations and interesting cases. I think my partner right now is can't plug in. So what will happen is that I will just be asking several questions to each of the what we call presenters. So I would start with presenter number 1, and dry and rough ocular surface and why. And I think sometimes this is about vitamin A, and also with a picky child case and the case report and the picky eater, also a vitamin A case. So my question for both is that did you find any unusual, or did you check the skin also of these patients of yours to see some signs of vitamin A deficiency?
So, hello, I'm from the second case, Levetta, and our patient had a papular rash on the skin, and the skin condition wasn't improving. So, we were very happy because when we started treatment with vitamin A, the skin condition also improved. So, we thought maybe it's from vitamin A deficiency because the examination was very difficult. The patient was diagnosed with autism and all diagnosis was difficult.
Okay. Yes, because sometimes you can see some of these, what we call the chicken skin. For example, if you check for the areas near the arms and sometimes on the thigh area near the knees, you can see some of the skin is not so smooth. And the reason I'm telling this because I used to have patients similar to yours for the first and the second case. And since I was just lucky that my mom is a dietitian, so she would always tell me that when we talk about it, that you check the skin immediately because children are really picky. And I do agree, just to add some inputs, is that even in well-developed countries, children can be picky because they like to choose the food they eat. But I have found out in some of my patients is that they don't tend to eat because what happens is that they play more with the gadgets, with the cell phones and the iPad. And so when they eat less and less and they eat fast because they want to be involved and go back to what they're doing. So, and yes, I think your use of vitamin A, how many units did you use per day?
So we used in total 600,000 units, 2,000 units first day, then 2,100 units second day, and 2 weeks later.
All right. Thank you very much. And
thank you.
The reason I just asked because in some cases you have to monitor this also because there might be like an excess of vitamin A that can lead to hypervitaminosis A, which is also the opposite. And it takes a longer for these patients to have, the skin color also changes to yellowish. And it takes a long time for this to disappear. And I think that's one thing I want to contribute. And you are lucky to have this vitamin A because now in the Philippines, we don't have this type of vitamin A medications or capsules.
Thank you so much.
Yes. And then for our third case, congenital corneal abnormalities associated with multiple disorders by Dr. Paulina Sharan.
She cannot join the conversation.
Okay, it's all right. But, for the sake, I would just add again, is that they use anti-VEGF, which is also very, very good. But also, if we don't want, in cases or patients who are what we call cooperative, sometimes we use an adjunct of doing photocoagulation to these new vessels so that the neovascularization becomes, corneal neovascularization becomes less and less. Now for the fourth case, ocular manifestation of skin disease, I think. Yes, this is by Paula from Lithuania. Is she around? Oh, I think she's not around. I think also with Agnieszka, so she's not around. I think I'll go straight to Dr. Krishna Kishore. Is she around?
I'm right here. That's me.
Oh, hi, hello, sir. Yes, very, very good lecture and very interesting. And I'm just curious because, where I practice, we don't know, it's a standard, becomes a standard always that we do the 24, procedures. When do you use this 10-2? What are the cases that you normally would start suspecting in your patients?
Sure. So typically, if the patient is very advanced and they already have advanced disease, we start off with a 24-2, then proceed to a 10-2. In this case, separately, and this patient was very particular. You kind of knew something was going on. So you perform all the tests. The 24-2 was normal, but the OCT kind of gave us some inclination, right? Along with some inferior defect on the visual on the optic nerve, was there some infratemporal thinning, and the OCT correlated with that. And then just to make sure, you want to rule out some retinal issues here and some neuro-ophthalmic. So in cases where you can't figure out what's going on and there's no direct OCT macula that's kind of showing you what's going on, then you get a 10-2, and more often than not, you can find that rare patient that has those defects. But typically for advanced fields who have that pinhole kind of defect, 360 degrees, then that's where we start following them with a 10-2. This was an abnormal case, with typically not a typical case where we do that. So it just happened to be, and plus the asymmetric IOPs, that this patient had some early glaucomatous changes. And we started on some drops. He's doing fine. In fact, I saw him this morning, actually.
So which means that in cases with asymmetric IOPs, these are the ones that should be what you call taken care of. I mean, much more in-depth.
Well, I think, yeah, if there's an inclination and the 24-2 shows some changes, then you can stop there. Here, the 24-2 didn't show anything. We didn't have any kind of inclination, except then we had to find out where the visual field defect is, and it was in the 10-2. But you're right, asymmetric IOPs, asymmetric cup to disc, that's where we were here. Yeah.
I think it's like a red flag.
Yep.
For this case. Thank you, Dr. Kishore.
I have a question. Yeah,
okay.
I just joined, so thank you for being with us, Dr. Kishore. And the question is, because I don't, but maybe you can repeat. Have you started treating this patient?
Yes, he started being treated. Yes, 100%. And the pressure's kind of normalized. Yes, just in that left eye.
Yeah. So what was the treatment introduced?
I think I probably used the prostaglandin analog there. Yeah.
Standard treatment. Yeah.
Yeah.
Standard approach. Okay. Yeah. Perfecto. Please continue.
Thank you so much. Yeah.
Thank you.
I think the presentation tonight, especially for the Enigma cases, was really something that makes us think. And I think they all gave what we call a little bit of everything from front to back. So I would like to thank the presenters, but I would like to give it back to Dr. Andrzej Grabowski, a very good friend, for the final talk.
Yeah, this is the time to, let's say, end the meeting, Case Reports in Ophthalmology 2024. I would like to thank all of the speakers for preparing the very educative talks, and those who joined us during the discussion even more. And I would like to thank our moderators for a very inspiring discussion. Always discussion is the second part of the conference. Hope, because this is the meeting that is repeated during the last 10 years every year. So I hope very much that we can meet together again next year. I can add that we had around less than 600 registered attendees to this meeting from all over the world. I do not have the whole statistics. I mean, regarding different countries, it is not possible at the moment. We will publish it later. However, well, I'm very satisfied to have such a great audience and very global attendance, and of course global also speakers from 4 continents. We have had speakers from 4 continents this year. So thank you so much again. And well, last thing, if you have any interesting case and you want to publish that, you can contact me. I have mentioned that before, that we do have some journals that publish case reports, and we can help you to publish that. Again, thank you and see you next year.